Welcome to the NCCN Policy Summit, Defining the New Normal 2021, and the State of Cancer Care in America Following 2020. My name is Robert Carlson, and I have the privilege to serve as Chief Executive Officer of the National Comprehensive Cancer Network. On behalf of everyone at NCCN, thank you for attending today's summit for what will be a very timely and informative series of conversations. 2020 was a challenging year for our country. We endured the spread of a novel, life-threatening virus, one that has changed the way we work, access education, and congregate. We experienced a contentious presidential election, one with serious implications for how healthcare will be provided and reimbursed. We were confronted with acts of institutional violence against American men and women, George Floyd, Breonna Taylor, Atatiana Jefferson, and countless others. These acts have sparked an intense national conversation about other disparities, structural racism, and the need for anti-racist policies. For oncology, these watershed events play a critical role in shaping the future of cancer care for manufacturers, payers, providers, but most importantly for patients and survivors. Today, we will discuss the short and long-term implications of these events on the cancer care delivery system. We encourage you to engage with our speakers by submitting questions via the Q&A button. We hope you will consider engaging through your social media platforms using the hashtag NCCNPolicy. The topics are far too complex to fully address in one day, and we hope that the oncology community will continue these conversations by carrying them online and in person to those who are unable to attend. NCCN would like to acknowledge the many supporters of today's program. Without the support of these organizations, the summit would not be possible, and we thank these organizations for their support. Today's agenda will cover these issues through a combination of keynote presentations and panel discussions. We welcome all of today's speakers and thank them for their time and for sharing their expertise. Our moderator for today's summit is Clifford Goodman. Dr. Goodman is Senior Vice President at the Lewin Group, a premier national healthcare and human services consulting firm. Dr. Goodman has over 30 years of experience working with government, industry, and nonprofit organizations in the US and abroad in areas such as healthcare technology assessment, comparative effectiveness research, clinical practice guidelines, and health economics. NCCN audiences are very familiar with Dr. Goodman's moderating ability, and we're thrilled to have him join us for today's discussions. At this time, allow me to introduce our morning keynote, Murray Aitken. Murray Aitken is the Executive Director of the IQVIA Institute for Human Data Science and Senior Vice President at IQVIA. As head of the IQVIA Institute for Human Data Science, Mr. Aitken provides policymakers in the global health sector with evidence, analysis, and insights to accelerate their understanding of global trends in disease, data science, and technology. A frequent speaker on international healthcare, Mr. Aitken's perspectives have been widely covered in the Wall Street Journal, the Financial Times, Fortune, and Time, to name a few. Mr. Aitken holds an MBA with distinction from Harvard University and a Master of Commerce from the University of Auckland in New Zealand. We're thrilled Mr. Aitken has joined us this morning to share some of IQVIA's oncology data insights and insights on the impact of COVID on cancer care. Mr. Aitken.
Thank you, Dr. Carlson, and thanks to NCCN for this opportunity to kick off this policy summit. I'm delighted to be with all of you today. What I have prepared is a short presentation that is fairly numbers oriented, if you like, to talk about what we have seen at the IQVIA Institute in terms of the impact of the pandemic on cancer treatment and cancer care. This content is drawn largely from a recent report that we have published Global Oncology Trends 2021. It's available on our website. It's in the public domain, and it represents an annual look at the state of activity in and around oncology treatments and trends. And I invite you to download that report. We have others published as well, as you can see on this page. But today I'm going to run through what we see as some of the key numbers that we think are helpful to position where we are, where we've been over the past year, and where we are today as we come through the pandemic. Briefly touching on what we see in terms of oncologists' reported caseloads, the impact on patients and their care as seen through the eyes of oncologists. We'll talk about screenings and misdiagnoses, which we know is a topic of great interest and concern. We'll also look at some evidence we have around patients initially presenting with metastatic disease and how that trended last year. And then the broader use of oncology medicines, including checkpoint inhibitors and how that played out during the course of the year, as well as the mix of formulations of oncology treatments that we saw as well. Again, these are going to be snippets of information, but I hope that collectively they paint the picture of where we have been and where we are today. So let's start with what we're seeing in terms of oncologists reporting their caseload levels. This is derived from research that we conducted in the US across the 4 major European countries plus the UK, as well as Japan. And we did waves of surveys, of polls of practicing oncologists, about 700 in total, 4 polls through the course of last year, and most recently in February of this year. And here we're showing the reported reduction in or level of caseload of oncologists relative to the pre-COVID-19 phase. So for the US, if you can trace that line through the middle here, in April 2020, oncologists were reporting their caseload was 49% of the pre-COVID-19 level. It rose to 60% in June, 77% in October, and as of February, was reporting 74% of the pre-COVID-19 level. In other words, a 26% reduction from the period prior to the pandemic. You can see that relative to other countries, that means that the US as of February is showing the lowest level of caseload reduction. Germany, on the other hand, which you can see spiked in June, fell dramatically as the year progressed, and the caseloads there are being reported at 49% of the pre-pandemic level. So this is one view of what oncologists are seeing. We also have asked oncologists about the impact that the pandemic is having on the type of care that they are delivering to their patients, and asking that around surgery delays, fewer diagnoses occurring, delays in chemotherapy, and changes in treatment from infusions or injectables to oral formulations. So just looking at the top line, which is the showing the US, a very high percentage, between 74 and 77%, signaling that they have seen delays in surgery for their patients. Over half seeing fewer diagnoses, almost 50% seeing delays in chemotherapy, and 40% most recently indicating that they are seeing a change in treatment to oral formulations when they are available. Interesting to also compare the US to Europe, relatively similar patterns, I would say. Japan, which is a different oncology environment, shall we say, slightly different than what we're seeing in Europe and the US. We have also been tracking the use of telemedicine. We know that this is one of the responses to the shutdown back over a year ago. And again, here we're tracking the percentage of patients on remote consultations as reported by the oncologists. And that clearly spiked in April from the pre-COVID-19 level, which was in all countries less than 10% of consultations, but went as high as or over 70% in one country in April. In the US, it went up to 46% of consultations. It has then drifted down since then, and most recently in February in the US, 26% of consultations were reported as being remote. We also asked oncologists what they expect post-pandemic, post-COVID-19. And here in the US, what we heard back was an expectation that perhaps 20% of their consultations will be virtual on an ongoing basis. Of course, not a lot is known yet about exactly what these consultations constitute, how they fit with in-person consultations, how many of them are incremental interactions with the patients beyond what they would typically have done in person. So I think the nature of these remote consultations, the role that they play in caring and delivering care for the patient, and indeed the impact they have on care and outcomes is still not really understood. And I do think this is an area that we should all be watching and paying attention to in the coming months. What we do know is that oncologists have been spending more time providing support to their patients in terms of discussing COVID-19 and providing other kinds of support. You'll see in a minute that is related to the pandemic. So here we're showing the results when we asked oncologists about how much of their time spent with patients is spent discussing COVID-19, and it ranges from 16 to 20% across the countries shown here. And a full third of oncologists report that they have increased their patient support that they provide their patients due to the pandemic. This is also now showing what it is that the nature of the impact to patients that the oncologists see in their interaction with patients. Leading in the US with 59% of patients experiencing financial hardship, and that being observed by the oncologists, as well as experiencing logistical challenges because of new ways of working and interacting with others. Also a significant disruption in terms of cancellations and delays in getting doctor's appointments. So again, I think this is what we've all frankly personally lived through in one way or another over the course of the past year, but with respect to cancer patients and their journey and what they are dealing with, this is clearly a very significant impact. And it has an impact on the oncologists who are providing that care as well. Turning to the issue of screenings, again, this is something that we know has been of intense interest. This is now based on IQVIA data, based on which comes from claims submitted by clinics, by oncology practices, hospitals, screening centers, sort of whatever flows through the system for reimbursement purposes. And here what we have done is looked at the level of claims related to diagnostic testing compared to baseline levels and a baseline expectation. April 10th was the week that we saw where we saw in the US, and this is all US data now, where we saw the greatest decline relative to expectations in terms of diagnostic testings occurring. Mammograms down 87% that week. Pap smears down 83%, colonoscopies 90%, and CT scans down 53%. Since then, we have seen an improvement, so that if you look through the end of the first half through the second quarter, last year it was down more in the 50% or 27 to 50% range, and then extending through to the end of 2020 for the full year. We are estimating that there were 20% fewer mammograms, 14% fewer pap smears, 23% fewer colonoscopies, and 11% fewer CT scans. What does that translate to? In total, and if we use as a baseline the American Cancer Society's published numbers on typical levels of annual diagnostic testing that occur for these four cancer types, and you apply the reduction that we report from our data, that all translates into about 22 million fewer screening tests for these four cancer types occurring in 2020 compared to what would normally have occurred. If you then apply a rate of positive cancer diagnoses per test, then you can yield a theoretical number of delayed or missed cancer diagnoses that didn't happen in COVID in 2020, and that adds up to about 68,000 patients. Now, we need to be careful with these numbers. The rate of positive cancer diagnosis is a number that's not entirely well established, I might say. Plus, we're not making any adjustment for a change in the mix of patients who did get screened in 2020 and how representative they were of typical sort of pre-pandemic screening levels and mixes of patients. So there's a number of variables at play here, but we do recognize that with 22 million fewer screening tests, again, only across these four tumor types, that 2020 was a year of disruption, of missed diagnoses, and the implications that has going forward through this year and beyond, I think is something that we will be talking about today, and has significant consequences for oncologists and as well as for patients. So while we can focus on the impact of the pandemic of oncologists, I did think it would be interesting just to sort of compare how oncologists and the field of oncology compares to some other specialty areas. And in fact, when you look across the course of the year, relative to other specialists, oncologists actually saw the least impact on diagnosis visits during the lockdown. So, here we're comparing with half a dozen other specialties. You can see that derm really fell the steepest in April, although you'll also note that in July it recovered the most rapidly in terms of diagnostic tests conducted by dermatologists. You'll also see that, as the year progressed, primary care administered diagnostics recovered to, but still were about 14% below the base period. Oncologists, based on this view, were down 25% in terms of diagnosis visits made by patients to oncologists. So again, that provides a little broader context in terms of what's been happening. We also have tried to understand what is occurring in terms of new patients presenting with metastatic cancer. We're now drawing on a different IQVIA data set, which is a panel of 400 US-based oncologists that I would say skews towards community-based oncologists, where we have asked them, and we track consistently, what percentage of new patients they see have metastatic cancer. And here we've indexed these 5 cancer types against a baseline, which is the average of the 12 months ending February of 2020. And then relative to that baseline of 100, what did we see play out during the course of 2020? And you can see in all cases, except prostate, we saw a higher than normal percentage of patients, new patients presenting with metastatic cancer. And again, I think this is what everyone is concerned about, and particularly how this then extends into 2021. But over the course of the year, and again, this reflects the mix of patients being screened, the mix of patients seeking out care during the course of the year, that these have all trended towards more metastatic cases. The exception is prostate, but here we think this decline, in fact, is really because we're seeing more pre-metastatic prostate cancer patients being seen as new patients for oncologists because of the availability of some of the new treatments for them. If we turn now to looking at the use of medicines, we did see what we would call a precipitous decline in the volume of oncology medicines that were used in 2020. So what we're measuring here is defined daily doses of oncology medicine. So this is a purely volume metric, but every oncology drug has been converted to a standard defined daily dose, and then we run the analytics to show what that adds up to. And then here we're showing the growth over the prior year in total of that total number of defined daily doses. And you can see in all parts of the world, in US, Europe, and Japan, the growth rate fell in 2020. Notably in the US, it actually hit negative 0.1% compared to growth in volume that was more in the 5, 6, even 7% range in the prior years, with the exception of 2017. So in 2018 and 2019, that volume of medicines used in oncology treatment in the US grew 6.9% each year, and then fell dramatically to just declined 0.1% in 2020. So again, this is an issue of concern. It's a reflection of what I've been showing in terms of the reduced caseloads, the reduced number of patients being diagnosed and presenting, and indeed fewer treatments being initiated. We also took a look at the checkpoint inhibitors, just because they are such an important part of the armamentarium these days, and where the increased use of these immuno-oncology drugs has increased so dramatically over the past few years. The use of these inhibitors did continue to rise through 2020, both in the US and Europe. This also, by the way, shows the relative magnitude using, again, this defined daily dose metric per capita, and also showing that the US in 2020 is using about 40% more immuno-oncology checkpoint inhibitors per capita than the EU countries. You can also see the mix differs somewhat. But we did see a slowdown in the growth rates for the use of checkpoint inhibitors. Again, somewhat similar to the earlier chart showing the overall decline in all oncology drug use. So here we're showing that, again, if I just focus on the US, back in 2018, the number of defined daily doses of immuno-oncology drugs was up about 60% over 2017. That growth rate fell to 36% in 2019, and then dropped to just 12% in 2020. So still growing. The slowdown in the percentage growth had already started, but again, a significant drop in the use of checkpoint inhibitors during the course of the year. And then the final slide I have is just on this issue of the mix of oral versus sub-Q or IV infused drugs. And here we're showing monthly, this is actually based on sales value of these drugs since the middle of 2016 on a monthly basis. With a dotted line at the onset of the pandemic in the US. And you can see that actually looking at the growth rates that things had been moving around somewhat prior to the pandemic. In particular, we'd had the rise in or the steeper increase in the volume of oral oncology drugs starting back in 2018. I mean, we have been reporting that since 2015, about 60% of the new oncology drugs being launched have oral formulations. So part of this trend is also picking up the shift in the mix of oncology drugs towards oral formulations. And similarly, a decline in the relative share of IV that you can see was occurring prior to the onset of the pandemic, and then continued post-pandemic with a further decline in the growth rates of the IV or infused formulations, and continued stronger growth for the oral formulations. The green line is the sub-Q, which is a relatively small part of the overall portfolio, and a lot of this was about one particular anti-CD38 monoclonal antibody for which a subcutaneous formulation was launched for multiple myeloma, and that is a major driver of that increase. So if I sort of step back and reflect on what do all the numbers add up to, this is the way that I would summarize the impact that the pandemic has had on cancer care. We've had this significant drop in oncologists' caseloads that continues as recently as February from our data, and the delays in the surgeries and the chemotherapy, as well as the fewer diagnoses that are likely to lead to longer-term consequences. About a third of oncologists providing more support to patients, but also reporting that their patients have been facing delays and difficulties in pursuing their treatments, their appointments, as from a logistical perspective, as well as from a financial hardship perspective. Screenings down 11 to 23% in 2020. And by the way, this is continuing through 2021. So we still see screenings below the pre-pandemic levels. So the lost screenings is actually getting larger and larger. And I think we still face this question of how and when will this be turned around? And what are the consequences of those missed screenings? And how will that play out when those patients who have now undiagnosed cancer eventually get diagnosed and present and treatment initiated. We did see, and again, related to that may be the signs we saw in 2020 of more new patients presenting with metastatic disease. Again, part of that's just a mix of who made their way to the oncologist in the course of the shutdown and the pandemic, but how that plays out as patients potentially are getting diagnosed later in their cancer journey. We'll need to be watching that closely. And then this growth in oncology medicine use that fell precipitously in 2020 on a volume basis. There was no increase in the full year compared to 2019, even though checkpoint inhibitors continue to increase in their use, albeit at a lower growth rate. And then again, the dynamic of the mix between orals and IV infused, which did begin prior to the pandemic, we saw continue to trend towards greater use of the increasing number of oral formulations that are now available as the year progressed, and we expect we'll continue to see that next year. So with that, I will pause and pass back to Cliff.
Thanks very much, Murray. Great. I'm really struck by, if you kind of look across the data you've presented, the kinds of impacts along different dimensions, impacts on patients, on providers, on the delivery system, on innovation and more. So you can slice and dice the data in very important ways. One question backing up to your source of data for the US, was it primarily US claims data? And if so, how representative are those data for the nation as a whole? Do you think that they're nicely representative, or are there any gaps there along the way?
So for the claims data, which is the basis for looking at diagnostics, we have a large sample. Over a third of the country's claims are incorporated into that analysis. Exactly how representative, it's somewhat difficult to say, but just based on the magnitude and based on the source itself, we believe that is representative of large academic teaching hospitals, as well as smaller, more community-based care centers. In terms of the use of medicines, that data is tracked from wholesalers who are shipping the cancer drugs from manufacturers through to oncology clinics, hospitals, retail pharmacies, specialty pharmacies, wherever the drug is delivered or administered. It also includes direct shipments from manufacturers. So we're very confident that those volume slides are representative of the entire country.
Okay, always important to ask that question because we want to make sure we're reaching everybody to the extent possible. Several questions on some cuts of the data. One, do you have any data on the changes in the use of radiation therapy services? Any indication along those lines?
I don't have anything prepared on that. It would show up in our claims data. That's something we can take a look at later, but nothing I have to share today.
Okay, that was a couple of questions on that. And then there were several questions, Murray, about increases and decreases, for example, in oral oncolytics versus physician-administered products. Do you have any kind of take on why those changes might have occurred? There was a question about oral therapy sales declining sharply. Any sort of insights along those lines?
So there are multiple dynamics playing out. One is the mix of the new drugs that are reaching the market, which have been skewing more towards oral targeted therapies in the last 5 years. So the uptake of those drugs is definitely a factor. I think, just given the nature of the shutdown and both the patients' reticence about interacting with the health system, and in some cases the capacity of the system to see patients, probably had a more significant impact on infusion centers and use of IV drugs than it did orals. We know that orals were being, shipped directly to patients' homes during the shutdown. And so I'm not sure there was a lot of switching per se, but I think where there were formulation alternatives that the ability to actually bring that therapy to the patient, would have been a factor, and that would always skew towards orals. We do know that there's been some movement towards home infusion and provision of service. So that's also in there, but I think it's still been relatively small. Okay. So at the end of it's a combination of all of those that comes together in the aggregate view. So it's not one factor that drives the shift in the mix.
Got it. One of our folks asked about FDA approvals in 2020, where 2020 also saw a high number of approvals by the FDA in oncology. And given your data and kind of your broader perspective, Murray, can you kind of infer whether there was a lower performance for these new products as they've entered the market because of the pandemic? Was the uptake affected at all for the newbies, as it were?
The uptake of the new launches in 2020 trended below historical levels. How much of that is because of the nature of the molecules themselves and the target patient populations, and how much of it was because there were restrictions on, there was no in-person ASCO and the like. It's a little difficult to tease that out. What we do know, though, is there were a record number of new oncology drugs launched, 17, I believe, last year. 2021 is also tracking at continued historically high levels, and the pipeline of late stage and early stage cancer drugs continues to expand. And never been greater than it is now. So, from a pipeline of innovation on its way perspective, there was really remarkably little disruption in 2020. Obviously, there was disruption, but I think the response and the sort of the agility of all players to manage their way through that was really quite remarkable, and left the pipeline looking extremely strong as of the end of 2020.
Good to hear that. And I liked your slide comparing the impact on oncology versus other specialties. I think the impact and innovation was probably less. That's consistent with that trend. Murray, we can't get to all these questions. Several did come in. Can you comment at all about any differences across race, ethnicity, and/or income? Any insights along those lines within your data? I'm not sure if you could pull that off.
We do not track race and ethnicity, and very few places do. So we struggle with, frankly, data availability. It's another whole discussion. Sure. So I don't have anything clear to say about that, and I'd rather not sort of speculate without good data. But there is a lot more work to be done, and that can be done with some creativity in order to advance our understanding of these issues and to pull it into this kind of research as well.
It's actually a nice setup for some of the discussions we're going to have later on, but people do want those sorts of data, so something for us to keep in mind. And finally, what is the single, in a sentence or less, do you think is the single greatest lasting impact of the pandemic on oncology? Any single one, Murray, lasting.
I think it's the disruption to the routine screenings and diagnoses of patients. That to me is the major risk factor. That people who were used to having their 6-monthly mammographies or their colonoscopies every 5 years or 10 years, who lost the habit in 2020. Are we doing enough to ensure they get back to that habit? Without that, I think we we're in for a significant and sort of serious backsliding in terms of the progress that has been made in early diagnosis.
Well, that's an interesting point. And so there's almost a concern about a lasting behavioral response for people seeking screenings, which there's a big downside to that. Murray Aitken, if you could see all the questions we're getting for you, you'd be astounded. I wish we had more time.
I hope I can see them, because maybe there's a way to do a blog post or something and answer them. Yeah,
we'll share them with you, and if you're able to answer some of those offline, that'd be great. Murray, you brought the data, you brought the messages, you brought them at the right time. Thank you very much. What a great start. Thanks a lot, Murray. Take care.
Thank you.
We're going to move now to our first panel discussion. And you can see the folks there on your screen. This is on rebuilding screening, treatment, coverage, and trial capacity, all of them, for 2021. We've got several important questions to pose to our wonderful panel here. And I really think that Murray's data helped set this thing up. So you saw a lot of changes going on in the past 15, 16 months. We're almost halfway into 2021. What sort of recovery can we expect? What other kind of work do we need to do? Insofar as introducing our panelists, you see who they are and with whom they are. Starting with Keisha Brooks-Coley, tell us briefly why it is you find yourself in a panel on this topic. Keisha.
Good morning, and nice to be here with everyone this morning. Excited for the conversation. It was great to hear the last panel, and I find myself here because we're talking about a lot of the issues of what the new normal is in cancer care. The American Cancer Society Cancer Action Network had the opportunity to work on a project called the Elevating Cancer Equity Project this past year, along with the National Minority Quality Forum, looking at the impact of COVID on cancer care, and especially looking at the impact on Black and Brown communities from a health disparities lens, and what cancer care issues need to be addressed and policies need to be addressed. So looking forward to the discussion.
Great to have you, Keisha Brooks-Coley. You're the right person for this right panel today. Crystal Denninger, you're playing on your home court with NCCN. Can you tell us how you find yourself on this panel?
Sure. Hi, good morning, everybody. It's great to be part of this panel. So I'm Crystal Denninger, and up until April 1st of this year, I was a practicing GI medical oncologist who did early phase drug development and cancer survivorship, especially as it was related to GI cancers. And then in April, I joined NCCN as the Chief Scientific Officer, and I'm overseeing the oncology research program. So I think my role as a clinical investigator and clinician now coming into NCCN to see their research program sort of puts me at this panel.
Great, thank you very much, Dr. Denninger. Let's move to Dr. Christopher Lathan. Christopher, how is it you find yourself on our panel today?
Thank you very much, Dr. Goodman. I am I'm a practicing medical oncologist, specifically focusing on thoracic oncology, and I have been involved in cancer equity over the last 15 years in lung cancer screening, as well as in treatment, and more specifically looking at precision medicine. And in my role now, I'm the Chief Clinical Access and Equity Officer at the Dana-Farber Cancer Institute, and we have founded our Cancer Care Equity Program, which is a specific outreach program focused on federally qualified health centers and trying to bring a marginalized community into treatment. So I probably suspect that's one of the reasons that I'm on the panel.
It is indeed, Dr. Lathan, and because Dana-Farber is also a well-known research institute, we'll be interested in hearing about the role of equity in clinical trials, of course, as well. Jen Malin, welcome back. You're the CMO of Oncology and Genetics at United. Can you tell us how it is you find yourself on the panel for today's topic?
Good morning, everyone, and good to be here with you all. I lead oncology for United Healthcare. United Healthcare provides healthcare benefits for about 50 million Americans through commercial health plans, Medicare Advantage health plans, as well as Medicaid plans. And as well as that, I do still practice on a voluntary basis at the West Los Angeles VA hospital. So I also experienced firsthand with the patients that I was treating the impact of the pandemic.
Great. Thanks very much, Jen. Great to have you. This session is going to go until 11:25 Eastern Time. The main topics we hope to get to are preventive care and screening, resuming active treatment and palliative care, clinical trials, and some questions about treatment capacity, registration, and so forth. I just want to get started with preventive care and screening, and perhaps start with, I think perhaps with Keisha and Crystal for starters here. As you're seeing in-person services start to return to pre-pandemic levels, are you seeing any strategies or policies in practices or payers to try to implement some more continuity of care and prevention and screening? Kind of how are we recovering from this? Keisha, Dr. Denglinger, any initial thoughts?
Sure, I'm happy to start. As a patient advocacy and focused organization, the American Cancer Society identified a lot of the issues that were discussed on the first panel around the number of people who have not been able to access screening, and that screenings have declined. And it is something that we have been paying very close attention to and see as one of the solutions to make sure that we're educating people about how they need to get back to screening, making sure that they understand how they can catch up on their screenings that they have become behind in. We know we had our American Cancer Society 2021 Facts and Figures report that was released a few months ago that included information that stated that we know that NCI predicts that 10,000 excess deaths in the US from just even breast and cervical cancer alone in the US over the next 10 years will be an issue that we have to address because of the pandemic related delays. And one of the solutions that we are actively engaged in is talking to people, making sure that we're educating patients, making sure that we're educating providers to help us as well. So they're talking to their patients, and we're doing that through our Return to Screen initiative that includes a number of other patient and provider organizations as well. We have a lot of work ahead of us to make sure that we can get back to the place that know the importance of screening and they get back into a schedule of making sure they have access to those important life-saving screenings.
Absolutely, thank you. And I wonder, Crystal, if you're starting to see any hints along the horizon about any trends in preventive care and screening.
So yeah, I think, we're starting to see people come back into screening. I think at the beginning of this year, NCCN, ACS, and other organizations really put out a concerted effort to start educating the public, and then institutions themselves started to educate their patient base that it is time to get back to screening, that returning to cancer care and returning to healthcare settings was a safe thing to do, and that we should really be working on getting back to screening, because other healthcare outside of pandemic care is important as well. So I think both concerted efforts amongst organizations as well as each individual institution's organizational efforts to outreach to their patient populations, their caregiver populations, and the general public, that this is not only important, but it's safe to do, I think has been really sort of a widespread effort to really get the word out. And I think partnering between advocacy organizations, individual academic institutions, and then the general public and the lay press, I think is really important, has been important to start to get that information out there.
So basically we need all these players to be encouraging patients from all the different angles.
Yes, it's certainly a it has to be a multifaceted effort. It can't just be the healthcare providers talking to their patients. It has to be healthcare providers and other organizations providing public messages in addition to the messages to their patient base and to their caregiver base. So it really needs to be a concerted effort. And I think that's very clear that that's really becoming that effort beginning this year.
Thank you, Crystal, very much. I wonder, Christopher, from the standpoint of Dana-Farber, you provide a lot of cancer care. What are you seeing at Dana-Farber, and perhaps looking even more broadly insofar as getting back to preventive care and screening? And I'm just reminded of the data that Murray Aitken showed us in his last comment, saying there's some concern about a longer term behavioral response people may be kind of dialing back on prevention that may bother us. What's your view on that?
Yeah, so I've been very lucky. I have kind of my subspecialty clinic, which I still, have had for years at the Farber, and I also have more of a community oncology clinic that I do in one of our network sites. And what I would say is that screening wise, what we've been seeing is this conversation, as you've heard from Keisha and Crystal, about really getting people to come back to screening. That from a top level, that's happening. I mean, people are engaging, we're doing it individually. But where I find the trouble is that for marginalized communities, for working poor communities in my network sites, that's been a much more sluggish response, right? People have been coming back slower because if you think about it, think about the national conversation about the jobs that people have. Do they have jobs? Do they have insurance? And also balancing all of the issues that they're having. I'm seeing less of those folks come back and needing to be convinced a little bit more. There's multiple problems happening in your family, and screening is going to drop down. I would say for the subspecialty aspect of the Farber, we are still seeing our highly involved, highly engaged patients want to come back for screening. But the conversations I've had with working poor folks of all races, and specifically our Black and Brown communities, are a little bit different, where you have to really convince some folks, and some folks don't have the space, time, or insurance to come for their screening. So it's been a kind of a dual conversation, is what I would say at the Farber.
It's so interesting because I kind of think of Farber as sort of, one of the shining cancer centers on the hill and all that. But you mentioned your network sites. And so you really have a kind of a far-flung operation, and it sounds as though you are being able to see a range of responses throughout various communities it's no single slice. You're seeing it across the board. And now I'll push you a little bit more on this, Dr. Lathan. Are you seeing widening or narrowing disparities currently among those groups? What do you think?
Yeah, it's a little early. I don't want to avoid this question. I'm going to give you my opinion, Dr. Goodman, but I would say officially, it's hard to tell, right? We're taking a snapshot early on. We don't really know what's happening. Anecdotally, for whatever that means, I have seen more difficulty for patients to make it in, not only for their screening, but even for their first oncology appointment. So that where people are not. We're having a harder time. We're having to use the navigators to find people a little bit more and bring them in the marginalized communities. I think as far as my lung cancer clinic at the main campus site, that is full. People are coming back and that's happening. But what I'm seeing is a splitting of this response. And I think we'll get a better sense of that as the repercussions, the financial repercussions of COVID continue to go through the society. But that's what I'm seeing at least.
Yeah, that splitting of response is a phrase I'm going to remember now. We'd be kind of concerned about that. Jennifer Malin, you're one of the biggest payers, on the planet, on the commercial side. From the standpoint of a payer, are you A, observing stuff, B, doing something about what you're observing from the standpoint of United with regard to prevention in particular?
Yeah, so I think what we've seen in our data mirrors what some of the recent publications, which is that towards the last quarter of last year, we're starting to see a rebound in people getting screenings. We've seen less. That's been very much true of our Medicare and our commercial populations, but our Medicaid populations, we're not seeing quite the same rebound that we have in those other populations. So building off of what Dr. Lathan was saying, that there may be some disparities, and it's understandable, I think, to the extent that preventive care is not top on your list when you're struggling financially or trying to find work, right? That's more of a luxury item if you're in those situations. And I do share the concern. I mean, maybe less so that long-term we're gonna, people won't revert back to their healthy behaviors. I guess I'm more optimistic that people will do that, but I do have concerns that, the economic impacts from the pandemic may, change people's access to healthcare. So I think that, that's something I think we'll have to watch out for very carefully over the next couple of years. Things that we do as a health plan, so we do routinely have reminders to our members. We can tell when people are, individuals are due for their mammograms, for their colon cancer screening. So we do routinely send reminders through mail, through internet. When we get people on the phone with our case managers, they remind people to get those screenings. And we have active programs for those screenings that can be done at home, like fit kits for colonoscopy. We mailed over 400,000 fit kits to people's homes last year. And we will continue to do that as a, an easy way for people to be able to do screenings in their own home. Unfortunately, breast cancer screening and lung cancer screening can't be done quite as easily. But we do that, and are looking at ways to actually reach out to folks with the new recommendations dropping the age of colon cancer screening to age 45, looking to reach out to folks in that way as well. So I think concerted efforts along all these lines are going to be needed, especially for people who have other barriers in the way of getting back to their preventive care.
And Jen, as a great big commercial insurance company, is it fair to say that you are open to innovative approaches to increasing screening and so forth? It sounded like you've got several initiatives, but you're not going to hold tight with what you've got, right?
Sure. Yes, we're definitely always looking for new ways to incentivize people to get their preventive care and wellness care. And I would just say we're a big commercial insurance company, but at this point, we are probably almost have a pretty even distribution across Medicare and Medicaid.
Yeah.
So we really do, see and are now in the exchanges again as well. So we really see, the need to meet people where they are across all different points of access to the healthcare system.
So it isn't just, you're not one big insurance company, you're many, many plans, and you kind of bring some of that spread there. I'm just wondering, do any of you have a comment on whether or not the pandemic impact can be an inflection point for offering more community-based services, going out into the community, mobile access and so forth? Keisha Brooks Coley, is this an opportunity for that? Are you seeing any hints of it?
Well, I think that one of the things that we all know is that the health equity and health disparities issues that existed prior to COVID were areas that a lot of people were trying to address. And COVID just, it really shed a light on issues that have been around for many years, as far as individuals not having access to care. And, as Dr. Lathan mentioned, we saw a number of people lose their health insurance. So people who did have access to care finding themselves in a place that they did not have the ability to have the insurance to be able to go and get a cancer screening that maybe they were able to prior to COVID. And I think that we have to think of public policy solutions that can get to the communities and to the people who need access. And those are policy changes that are only going to make it so people have the access that they need.
Yeah.
And I think the other thing that I would just say is that we have to look at the levers that have to be pulled, ability for patients to have access to Medicaid. Not all states have Medicaid expansion. We have to look at that, looking at the cost of insurance, the need for individuals to be able to actually purchase insurance to be able to go and get the care that they need. And then even programs too that are federally supported. There's one nationally federally supported program, the National Breast and Cervical Early Detection Program, that provides pap smears and mammograms to low-income women who do not have health insurance. It's a healthcare safety net program that they can go and maybe start off at their federally qualified health center in their community and then get the referrals that they need to be able to get the cancer screenings that they need. And if a cancer is diagnosed, then they're automatically enrolled in the Medicaid program. So those are the type of levers that we really need to pull.
Good examples. Chris Lathan, any more insights on outreach, anything from Farber or elsewhere that you're seeing has changed as a result of the pandemic?
Yes, I think we're going to get to, I'll save some of the clinical trial innovation stuff to later and we get to that. But I would say specifically, there has been an acknowledgement that you have to come to the community a little bit more, following up on what Keisha was saying. So I think for the big cancer centers, the idea, and not just the Farber, our doors are open. We have an outreach program. We've been doing this. We've been engaging with this community. But I think what COVID showed us is you have to do that in a much more active, granular, and proactive way. If you want to speak to the Latinx community in your neighborhood, you have to go to them and talk to them and listen to what they are telling you. I think that's what COVID has shown us, that when we have these different effects in different zip code areas. And the Farber, I think, has done that. I'll give you a concrete example. I mean, as a cancer-only institution, what was the role for the cancer center during the peak of the COVID epidemic, right? And I think it was good that, they did actually realize the community is saying, we need these conversations to happen. And that's what they did. And they aided in vaccination, and not just the Farber, many cancer centers did. That is a conceptual switch, I think, that didn't happen pre-COVID. They would say, our job is cancer, and somebody else will do the rest. So I think we have figured that out a little bit, but now we have to make sure that continues, and we have to finish the job as continuing to innovate and engage with communities.
Great, thank you very much, and a good example. I want to move from preventive care back to resuming active treatment and even palliative care. Are any of you seeing a reluctance, a hesitancy, a fear about coming back into the system? I know kind of vaccination rates are having an impact and so forth these days, but are you seeing any still steep or lasting impact of concerns about re-entering care? Crystal, are you seeing anything, any data on that or inkling on that?
I think, so I think in general, people are getting back to care or didn't necessarily leave care. So I worked at Fox Chase Cancer Center, and throughout the pandemic, my patients who were in active treatment were anxious but still wanted to remain in active treatment and recognized that their treatment was important. So instead of exiting the care system, they exited society, or sort of isolated themselves away from other areas where there was risk, as opposed to isolating themselves from their cancer care. And so what we really found was that patients who were in active therapy and their family members who had patients in active therapy prioritized their cancer care and then worked to ensure that the patient remained as safe as possible. And then now that they're getting, now that we are getting vaccinated, there was at least in my patient population, there was a great excitement about the vaccine and motivation to get the vaccination so that they could feel safer and potentially then re-enter the rest of their lives because they had focused solely on their cancer care and trying to remain healthy. So I think that for at least from my perspective, we saw people remaining engaged in cancer therapy, but disengaging in other areas of their life where they thought that there may be higher risk. And, it does help that at our institution, Fox Chase remains sort of a COVID negative facility. And then there was a COVID positive facility that was separate from our hospital. And going to Dr. Lathan's point, the cancer centers stepped up and helped with supporting those other organizations, institutions, hospitals that were hit with COVID, even though we were not. But it did mean that our patient population really isolated themselves to ensure that they could remain engaged in their cancer care by kind of disengaging with a lot of the other aspects of their care, of their life.
Very interesting how patients kind of made their own decisions based upon perceived risk benefit, I guess, trade-off. Risk being COVID exposure, benefit being I want to still get treated. Jen Malin, are you seeing any sort of data trends that would reflect folks' willingness or lack thereof to return to care?
Well, I mean, in terms of cancer care I would say kind of consistent with Murray Aitken's presentation earlier, we didn't see the same amount of growth in 2020 that we saw in prior years. It was basically flat. And we would see dips. So like, kind of a slowdown in chemotherapy utilization, adjusted for membership, not in March and April so much, but a couple months later. So kind of thinking of like, if you, at least in my mind, it seems like if you imagined that there were fewer breast surgeries, let's say in March and April, then you would see fewer new starts of chemotherapy a few months later. But overall, I would say, in contrast to even back in March and April during the shutdown, the prior authorization volume for cancer treatments decreased by about 15 to 20% at its peak. But this was in contrast to other parts, all other prior authorizations for other types, whether you're talking about CT scans, rheumatology medications, everything else, their prior authorization requests decreased by 65 to 70%.
Wow.
So relatively speaking, cancer, yes, it was impacted by the pandemic, but I would say cancer care was much less impacted than other aspects of care. And, people, it's important. And, people, made, as Dr. Denlinger is saying, people made choices so that they could continue with their care.
This is, its own set of doctoral dissertations or something. In other words, the behavioral response by patient groups to their different kinds of healthcare needs, how these were influenced by various external and internal factors and the choice making that they took. So, gosh, we can't get to all that. I do want to move to clinical trials. Gosh, there's a lot to cover here. And well, Dr. Latham, we're going to start with you in this because I know you're set for that. The pandemic, as we know, did delay recruitment. It delayed or upset treatment regimens, data collection, and so forth. So what have you seen or learned about, and by the way, that's layered on top of historical disparities in enrollment and so forth, which lead to biased data on the clinical trial results because it's not a representative population, which leads to biases in care and so forth. So kind of coming through and out of the pandemic, Dr. Latham, what has been the impact or impacts on clinical trial enrollment and the downstream implications? And I'm going to ask that question for others of you as well to comment too, starting with Dr. Latham.
Yeah, I think, if you break the COVID experience into kind of the early experience where we shut down anything that was new, right? And many of us didn't have new clinical trials. People who were essentially being treated, we made sure that we kept that infrastructure. But everybody will tell you, certainly our outreach to marginalized communities was not at the top of the list during that time period, right? So now that we're trying to reopen and re-engage, I think what we're finding is there are some benefits. We found that we can do remote consenting if we have to, which we were told for years that we could not do under any circumstances. It would not be good. And it turns out we can. And that helps. I think kind of the idea, people are more open to the utilization of navigators in this arena to get to our marginalized patient populations. And then a conversation about transportation and costs it has to come to the cancer center. So I think when COVID, as we came up and started saying, how can we re-engage our clinical community and how can we get folks in clinical trials, these barriers became something very palpable. So that's the good side. I think the good thing is there were some innovations that we did that will have disproportionate impact in our marginalized community. The bad side, or the concern, I should say, is we still, again, our infrastructure of being in person, many groups in and around your communities, there are individuals, it's not an email culture. It's not a kind of a virtual culture. Yes, we've been doing this, but kind of the personal relationships are really important. And what we have been finding is it's been a little harder to get people engaged because you haven't been able to make have the same physical presence in the communities. And I think that's going to change, hopefully, as we continue on this trajectory. But that's where I would say that we haven't seen as much of an uptick. And the very last thing, because a lot of people want to comment on this, I think hiring has been hard for folks who when we want to re-engage our clinical trials nurses, and we have been able to get some folks to get out into our network sites where one of our network sites, 40% of the patients speak Spanish. We can't really recruit without a clinical trials nurse. And so we have been having difficulty getting folks and being able to open the trials there.
Those are some very interesting observations. The workforce thing I wasn't thinking about, because you need real people to do really interpersonal outreach to consider enrolling in a clinical trial, the upsides, downsides, getting consent, and the language issue, of course. Did like your comment about remote consenting. Didn't used to think we could do it. Hey, we did it now. We can still do it. So those are very helpful observations. Then the navigators and the transportation issue all going to contribute to enrollment and sticking with the trial. Keisha Brooks Coley, what are you seeing or thinking vis-a-vis the clinical trial enrollment and any kind of lasting disparities narrowing or widening accordingly?
Sure. So as an organization that advocates annually for federal funding for research and specifically cancer research, we have heard about, the fact that labs shut down, that research had been halted, that things kind of came to a standstill in some ways during COVID, and have had concerns about what does that mean about the important treatments and cures that we know our patients need access to. And so we have been advocating and continue to advocate for funding that could go to the National Institutes of Health to make sure that those extra dollars go towards getting clinical trials that had halted or research that had halted or labs that had been closed or significantly scaled back can get up and running again as they were, alongside advocating for additional funding for fiscal year 2022. But we're advocating for $10 billion to get that research and those clinical trials restarted and moving back in the right direction, and then $3 billion for research for the fiscal year 2022. But lastly, I would just say, as far as looking at clinical trials, and this is an issue that we focused on in our Elevating Cancer Equity project, and that project had some solutions, some policy solutions that we're working on. And it really is about what are the barriers to patient access to clinical trials, and especially making sure those clinical trials are diverse. We know that minorities are underrepresented in clinical trials, as Dr. Lathan was just saying. There are some policy levers we can pull on. How do we deal with ancillary costs? How do we make sure that patients don't have to worry about paying for dealing with childcare, all of those things that when you have an individual who may want to participate in clinical trials, that those are the barriers that will not allow them to, those day-to-day things that get in the way, even if they actually have gotten the information about the trials.
That's the striking thing, Keisha Brooks Coley, that you're saying, and it really underlines what Dr. Lathan said as well, which is it's really important to get our clinical trial protocols down and write the regimens the right way and get all the chemo right and all that. But you're not going to get the clinical trial with all these other aspects of communicating, navigating, transporting, childcare, what have you. It's not going to work. Crystal Denlinger, I know that you've been looking at clinical trials from a number of perspectives. Can you add to those observations?
Yeah, so I think as a clinical trialist, one of the biggest lessons that I learned in the last year was that we can pivot quickly and we can be responsive in clinical research. And that not only can we do it, but we actually did it pretty well. Over the course of the last year, FDA and NCI wrote guidance fairly early in the pandemic to help allow clinical trialists like myself to be able to continue to do research with protocol modifications that were in the best interest of the patient. We quickly learned how to do remote patient monitoring. We quickly learned how to do remote data monitoring. We used to have in-person data monitoring visits. Now all our CROs were doing remote data monitoring. We were able to figure out how to partner with local labs and potentially even local partners for certain assessments and things. And I think that what I took out of that as a trialist is that we really need to think about our protocols very quickly or very critically. Do we really need every single visit and every single lab and every single toxicity assessment? Because when we started the pandemic, we really went to our protocols and really asked the hard questions of the assessments that are required for a trial, how many of them are absolutely necessary for patient safety, but also how many are necessary for data integrity. So now as we move forward, I think we need to have a critical eye on our protocol development to not only make sure that we have the necessary patient touches to ensure data integrity and good results, but also that we're not over requiring people to show up, because I think that ends up being a barrier to care. If you are saying that somebody has to come in day 1, day 2, day 3, day 4, day 5, day 8, day 15, day 22, well, you know, if you're trying to work or you have childcare issues, that may not be something that someone can do, especially nowadays. So I think we really need to think critically about our protocols and what we need for data versus, you know, what's just nice to have.
This is so interesting. We're experiencing a system, let's call oncology clinical trials, that has undergone a tremendous, largely unexpected set of stressors. And what has happened as a result of that large set of unexpected stressors? The system has had to respond by forcing to be more efficient and say, do you really need that 8th and 12th and 14-day visit? Do you really need those last 10 data elements? And on the flip side, what else do you need? You need navigation, transportation, workforce, the right language, and so forth. So it's interesting how the system may come out for the better in many ways because it was put under such stress. So thank you for that set of observations. Jen Malin, just wondering, what you do depends on ultimately innovation. You want to offer the latest and greatest to your beneficiaries. Are you seeing any trends that will affect ultimately any activity you've got to support clinical trials or to help fund them and or to benefit from their findings? Jen Malin?
So, I mean, personally, I think that, the adoption of telehealth during the pandemic has the greatest potential to disrupt and improve access to clinical trials. In terms of policy levers, I think, some of the restrictions on state licensure, requirements that were lifted to facilitate telehealth. I think if we could see extensions of that, it would facilitate second opinions at academic cancer centers that I think would also, provide in addition to facilitating, telehealth potentially being a vehicle to facilitate check-ins during a clinical trial and not requiring people to travel as much to participate in a clinical trial. I think it could also facilitate even just the types of second opinions that would facilitate recruitment of individuals into clinical trials. So I think that I see really telehealth and the different policy changes that have enabled that to flourish during the pandemic as being critical to really reducing disparities in clinical trials going forward.
So potential upsides of what ought to be a lasting, not ephemeral impact of the pandemic itself. Telehealth at the top of the list with many applications, including some we hadn't even thought of. With regard to slight switch of gears here in the care setting, having to do with clinical trials a bit, Keisha Brooks-Coley, what have we learned about strengthening the environment of trust in oncology care? The clinical trials thing made us think about this because clinical trials, you got to put your trust in somebody that the trial is worthwhile, that you're being appropriately treated. There are historical reasons to be concerned about enrollment in trials and so forth. What have we learned about improving the environment of trust in this setting? Keisha Brooks-Coley?
I think that I can reference some of the polling work that we did for the Elevating Cancer Equity Project, and what we learned from that project that was very fascinating. We was that patients and caregivers said that they didn't participate in clinical trials because their caregiver, their provider didn't actually make them aware of it. That they had gone through cancer treatment and interacted with their oncologist, and it was never brought up. We also learned that, from the caregivers and the patients who participated in the polling project, which was geared towards African American and Hispanic patients and caregivers, we found out that they oftentimes don't believe that they receive the same type of care that their white counterparts do. And those are issues that we have to address. And it's an issue of systemic racism and issues that we have to deal with in our healthcare setting. That COVID has allowed us to actually have a more comprehensive conversation about. I think a lot of us look for silver linings over the past year and a half in COVID, and one of those silver linings is really looking at health disparities, because we know that Black and Brown communities were impacted more by COVID as far as the number of people who actually died from COVID. That allowed us to question why. We found out that we didn't have the data that we needed to even understand it. And then from a clinical trials perspective, again, knowing that we're never going to successfully get more people into clinical trials from diverse communities if we're not providing information, educating, and making sure providers have the information they need to give individuals the information that they need. So there's a lot of work that needs to be done still.
Chris Lathan, one item to add about improving the environment of trust that we might have learned recently, just an item or two?
Yeah, so clinical access. This is a conversation that was not really happening the same way, maybe even 5 years ago. We talked about disparities research, we talked about equity, but we weren't talking about what's the pathway to get to the door, to get to what Keisha's talking about. How do the patients get to you? So that's where I would say that is a conversation that's happening now, again, because of COVID. Institutions are looking at clinical access for the marginalized communities, whether it's rural, socioeconomic, race, language. What are the structural barriers, not just that our doors are open?
Got it. Good. Well, a closing question then for the four of you, and it has to do with why you're dissatisfied. Okay, so we're coming out of the COVID pandemic. We've seen some upsides and downsides, but when you come into work, I was going to say Monday morning, but these days you come into work 7 days a week, any time of day, I know that. What is still kind of bugging you about where we are and where we need to go to pull ourselves up and out of the pandemic? Now, this could be clinical, it can be research, it can be outreach. What is the thing that's just bugging the heck out of you that says, why haven't we fixed this yet? And Dr. Denlinger, we'll start with you. I know you've got a great big kind of set of horizon there in this. What's bugging you? What do we really need to work on now? And it's just a sentence or so.
I think one of the things that I think we need to work on is figuring out which groups need which services or which outreach or which platforms. So for example, telehealth, I think, is a great opportunity, but for whom? Is it really everybody? Is it particular patients? Is it particular risk groups or maybe low risk groups? And how do we utilize the lessons that we learned in the pandemic in clinical research to actually make clinical research better? We clearly know that we can change, but now how do we use those changes to make lasting changes in clinical research to make it actually more accessible and faster, better, stronger? So I think those are the two things, really: risk stratification and how do we use those lessons to turn things around quicker this time?
So you're about being more discerning and proper identification and targeting of the greatest opportunity to diminish risk, as it were.
To some degree, yeah. Understanding who, like the different groups that are engaged and how do we target those groups specifically with the tools that we developed and or utilized during the pandemic. Got it.
Keisha, what's bugging you the most about what we got to fix and haven't fixed yet?
I think I would say it's actually information that we already have that needs to be expanded around patient navigation. We know patient navigation works for underserved populations to make sure, especially if they have a disease like cancer, they have those extra layer of supportive services they need to navigate the healthcare system. And I think that we have to figure out how do we do that in a way across care settings that makes sure that allows patients to have the access to the care that they need, making sure that they're getting their screenings and all the things that are important for a cancer patient or individuals who have other serious illnesses. We know what we need to do. We just have to expand the access.
Got it. Thank you very much. Jen Malin, from your standpoint, I know that there's always a lot on your plate across all the diverse plans and so forth. What do you want to get up and fix as soon as we can?
Well, I think the issue that continues to frustrate me, and I think frustrate all of us, is just, the fragmentation in our healthcare system that make it challenging to coordinate any of these programs, right? And so, we were talking earlier about outreach for cancer screenings and what our different organizations are doing. But the reality is, because we aren't really able to have a coordinated effort, we each might, all be reaching out to one person. So one individual might get, outreach and reminders from 3 or 4 different, health systems, health plans, and organizations. And then someone else might not get a single, prompt. So, how do we better coordinate so that, we're not duplicating efforts and we can use our resources where they can have the greatest impact? And, there's a number of things that are kind of table stakes to this, better integration of EHRs and integrating our data systems. And none of these are easy, but these are all, I think, and some of them don't even sound necessarily that exciting or innovative, but they're really critical, I think, to being able to deliver better healthcare and to keep healthcare affordable.
Got it. Thank you very much, Dr. Malin. Very helpful. Dr. Lathan, surely there are a bunch of things you'd like to fix pronto, but what's at or near the top of your list here?
Yeah. So the first thing is representation. So, we've talked about a lot of things, but you can't get to your diverse groups if they don't see anyone that looks like them. And we know that problem in medicine has gotten worse, specifically for African-American and specifically for African-American men in particular. So that's one thing, and that's a major societal issue. The other thing, I think, is recognition of healthcare innovation and systems research and how we should do it. And I'll be specific. I know we got to go, but what I'm talking about is there are small changes that we can make. There are changes that we can make, that we can do interventions to change things. We have a tendency to say, well, it's not a randomized trial. I don't really know. These things are hard to publish. Academically, it gets tossed aside. But the truth is, on the business side, we do it all the time. We make some changes, we do a pilot, we implement things. And I think that we need to think about some of these. You want to get out to patients, you want to get to different communities, you want to integrate navigators into your system. Let's do it, measure your pre and post, look at this, do whatever evaluation you need to. We need to recognize that work as well, because that's what change is going to be.
Very helpful, thank you. I'm going to toss a bonus question at you because I've seen a bunch of things come in over the transom, and I'm going to roll them up to one, and you don't all have to answer this if you don't want. But I'm going to try to represent a question here and try to squeeze this one in if you don't mind. What do we do the next time we get a shock to the system? What do we do the next time we get a shock to the system? We've talked about how the pandemic shock to the system 2020 into early 21, how we responded to that. Surely you and or your home organizations have had to think about what happens next time, and are we ready for that? And we didn't talk about this ahead of time, and nobody, I don't know if you thought about it, but does anybody have a notion for the next time we get whacked by something big? And it can be healthcare more broadly or oncology more specifically, but stuff happens. Crystal, you look pensive. I wonder if you've conjured anything up. Keisha's smiling. Maybe she's got something in mind. I know we didn't talk about this, but do you have a notion on that? Next big shock to the system. It's going to happen sometime.
Well, I'll just say,
Jen.
I think, despite, the challenges that we've been talking about today, I mean, I think the reality is, healthcare systems, physician practices, health plans, we all pivoted really pretty quickly. And I think, yes, given the circumstances, I think we've done a remarkable, at least from what I can see from our claims data, people have done a remarkably good job continuing to provide care for cancer patients and the people who need it most. So, I think kind of continuing those learnings in terms of, how do we marshal resources and focus them, we can learn from this and rise to the challenges that Dr. Lathan and Keisha have been talking about.
Okay.
And so why have it take a crisis for us to focus on these big problems?
So Jen Malin is saying we've learned how to be resilient. Any further comments on this?
And you always make things much more clear, Cliff.
Okay, well, we'll see. Any further comments on this one? Thank you.
So, just thinking about this, I think, we should start the learning process now and not wait for the next crisis to figure out what to do. From crisis comes opportunity. And I think this is a great opportunity to really go back and look to see what worked well, what didn't work well, where our pain points are, so that we are better prepared for the next crisis. There's always going to be an unseen crisis. And what we've learned is that we can not only be resilient, but healthcare can pivot quickly. And that's great. So we know that we can do that. So let's learn from what we've done, learn where we still need to really work hard, and then use the tools that we developed quickly, refine them, perfect them, and then implement them so that by the time the next crisis comes around, we're already better prepared.
Sounds great. Well,
can I just squeeze this one in? I'm sorry.
Please do.
I just want to say that we pivoted quickly. We did it on the backs of our whole staff. And what we also recognized is that our clinical infrastructure is thin. So what we need to learn for the next time is we need more. We need more of everything. Physicians, nurses, PAs, NPs, and we can't rely on the backs of the folks who want to do the great job, who will stay up all night and get it done. We have
that great pivot to which you all referred was on the backs of a lot of heroic people who worked too much time overtime and at great risk to themselves and their families. So maybe we can assuage that next time. Well, we are out of time. I did kind of give you that last kind of big impact question, but with a group like Keisha Brooks-Coley, Crystal Denlinger, Chris Lathan, and Jen Malin, I knew you could come up with this stuff, and you really did. Thank you all very, very much for your commentary, being quick on your feet, and bringing some really pragmatic, practical, and still optimistic viewpoints to this issue that we've all faced. Thank you all very much. Well, welcome back, everyone. Cliff Goodman here again. Welcome to our second panel discussion. We're going to talk about innovation now. This is entitled Using Innovations from the Public Health Emergency to Propel Cancer Innovation. So we've got innovation on both ends of this panel session title, and a variety of topics to cover. I'll tell you about them in just a moment. This session will go to about 12:25 p.m. Eastern, thereabouts. And so we've got a good chunk of time here. We've got 5 splendid panelists. And starting with Jeff Allen, I'm going to ask each of our panelists to introduce themselves and say how it is they find themselves on a panel having to do with innovation in cancer care. Jeff?
Great. Hi, Cliff. It's good to see everyone. Thanks for the invitation to join you today. My name's Jeff Allen. I'm the president and CEO of Friends of Cancer Research, which is a policy and advocacy group in Washington, D.C. I find myself, I think, on part of today's discussion, largely based on a fair amount of work that we have been engaged in with the Reagan-Udall Foundation, the FDA, various different data partners and methodological experts around the COVID-19 Evidence Accelerator, which was really geared toward looking at ways that real-world evidence could help augment the learnings that were rapidly emerging throughout the duration of the pandemic. And I hope that today we'll have the chance to discuss some of the lessons learned that perhaps might be able to apply into the future related to that as well.
Thank you very much, Jeff. You're well placed for this panel today. Thank you. Moving forward to Sarah.
Hi, Sarah Allward. Great to be here as well. I am the Vice President for Real World Data, Real World Research at Ontada. For those of you who do not know Ontada, we are McKesson U.S. Oncology. I am a real world evidence evangelist. So I think I find myself here in that as we have are on the tails of this major emergency, how we can continue to use real world data and the learnings over the last year to continue to accelerate innovation in oncology and continue to make sure that we're pushing forward not only the clinical trial research, but the use of real world data as much as we can and to its fullest extent.
Thank you, Dr. Allward. Great to have you. And Dr. Cruz.
Yes, good morning. I'm delighted to be part of this panel, and I am the VP and Medical Director for the Seattle Cancer Care Alliance Network and Community Program. I am here on this panel, I think, because I've participated in a number of other discussions about innovation in response to COVID, and as ground zero here in Seattle of the pandemic late February of last year, we really had to rapidly mobilize innovative approaches to cancer care delivery, and I helped to spearhead our telemedicine response.
Excellent. And we will be asking you about that, to be sure. Thank you. Gwen Darian, good to have you back.
Great, thank you. Great to see you, Cliff, and thank you to NCCN for inviting me to participate. I'm Gwen Darian, and I lead patient advocacy, education, and engagement at the National Patient Advocate Foundation and the Patient Advocate Foundation, and I've been working in patient advocacy about 25 years. You're going to hear in a later panel from my colleague, Shanta Chambers, who leads our health equity and community engagement work. So she will talk more about some of the experiences from our organization of the patients that we serve. But I think I find myself on this panel because I will say, as a 3-time cancer survivor, I am not a silver linings kind of person. But as having survived cancer 3 times, I am absolutely an optimist. And so what I'm looking at as we're looking at the pandemic, and also following on Cliff's last question and some of the things in the last panel, is what are the lessons that we learned? How did we pivot? But also, what are the problems that are intractable that we have to prioritize, that have some of them that have not been solved through the pandemic, and where equity and access and affordability have only been broadened and the chasm has only gotten wider.
Great, thanks very much, Gwen. And then Timothy Kubal. Dr. Kubal?
Hey guys, thanks Cliff, thanks everybody. So I'm Tim Kubal. I'm a hematologist at Moffitt Cancer Center down in Tampa. And I think I find myself on this panel for 2 reasons. The first is I'm the co-chair of the NCCN Best Practices Committee, which came together, frankly, weekly during the pandemic as we rolled through the country to see what are the things that were changing, how are we adjusting, how could we work together to get towards a consensus for change. So that was one of the big reasons. I also lived through it like the rest of you guys, so I've seen a lot of these innovations. A third brief reason that I'd be on this is because my wife decided not to kill me this morning since we had a baby yesterday.
Beautiful.
Baby's awesome.
Absolutely beautiful.
So I am excited to help us move medicine forward today, because this is a wonderful baby and a tremendous blessing. So I'm excited.
Well, we are so happy to have you and our honorary young panel member as well. Thank you very much for joining us, and thank you very much to your entire family, starting with your wife and mother. Thank you very much. What a great event. Some of the topics we want to get to today at the top are electronic health records and apps, mHealth and PROs, and of course, as you've already heard, real world data, related analytics, and even predictive models. So there's a lot to get to here. I want to start out with EHR's electronic health records and some of the kind of accompanying apps and so forth. And maybe starting, maybe Dr. Kubal, starting with you, and then I think maybe getting some input from Moffitt would be good point here on electronic health records, and Jenny Cruz as well, perhaps. What have you seen change or evolve as a result of the pandemic insofar as the utility and applications of electronic health records?
Well, I don't want to speak out of turn as somebody who just got 2 hours of sleep on a couch in a hospital, but I'll tell you what's interesting is the electronic health record itself didn't change very much, right? It's still a data input tool, data in, data out. What changed was the way we used it during the pandemic. And so Jenny can certainly speak to the telemedicine component. That changed my life as a hematologist and the life of my patients. But then also just the way that it reduced the barrier to communication. So Cliff, for example, I'm going to get 6 or 7 message center messages this morning from patients saying, congratulations on your baby. You don't do that typically, right? But these are people, we've been through something together, and the EHR gives us an opportunity to be a community. And I think that makes patient outcomes better. So while the EHR itself hasn't changed, I think the way that we've used it and leveraged it for our patients has made better relationships through the pandemic.
So interesting. So same technology, different applications of it. That's a very helpful angle. Thank you. Dr. Cruz, a similar view. We'll get to telemedicine a little bit later, but EHRs in particular, your observations.
Yeah, no, I agree with Tim. I think that the EHR itself hasn't evolved or changed very much in response to the pandemic, but the interaction of patients and providers using the EHR has, and I think it ties into telemedicine in some ways, in that it's another form of virtual care. So how are we incorporating patient portals? How are we using patient messaging to take care of patients when they can stay local and not need to come in because of the dangers of travel during the pandemic? And how can we leverage that going forward so that that virtual interaction can continue and almost make the EHR more of a communication tool and an education tool for patients rather than just a record of their medical care.
Can you say a little bit more about how an EHR becomes a communication tool with patients? And I want to set up Gwen Darian on that as well from the patient perspective. Dr. Cruz?
Yeah, so how can we use that as a mode for pushing information to patients and a mode for receiving information and questions from patients so that in real time we can virtually address their concerns and send them information that helps them manage their conditions more effectively without a necessary face-to-face interaction.
Got it. Very helpful. So Gwen Darian, I know that you've had perspectives on EHRs before the pandemic, and we kind of gone through the last 15 or 16 months with it. What are you seeing with regard to the patient interface of the EHR, how it's used coming out of the pandemic?
So I think this was starting before the pandemic, but I think the pandemic has clearly accelerated it. But I think of it not just as a tool for receiving and giving information, but as a tool to really promote patient empowerment. Because after all, these are our records. This is our information. And one of the things that can be done with the EHR is, rather than just kind of keeping it looking at the healthcare provider, the patient and the healthcare provider can partner in their use of the EHR. And likewise, the same thing with using the laptop and using the internet. And I know we talked about this earlier. I mean, 25 years ago, when I was diagnosed with my first cancer, if my oncologist didn't know the answer to everything, I would think they were terrible oncologist, and I would want to change and go to somebody else. Now, my breast oncologist, she and I look at things together, and it actually gives me comfort that she says, let me make sure that the guidelines are absolutely up to date. Let me check the latest evidence. And that assures me that she is a good, curious, always learning doctor. So I think it's a patient empowerment and partnering opportunity that we can really build on post-pandemic.
Interesting. You're using it sort of as an indicator that your clinician is kind of checking in, is tuned in. That's very helpful. And thanks for the reminder about patient empowerment. After all, it is our information. Yes. I, for one, need to be reminded about that over and over. I kind of forget like who owns all this stuff.
Yeah.
Sarah Allworth and then Jeff Allen. So how has the role of the EHR changed in a way that supports your work? Is it a kind of enhanced tool? How does it support the stuff you like to do, Sarah?
Yeah, I think one of the things that came from the pandemic that was important, and I'm a measure what you treasure type person. So making sure that if we're going to collect data, we're making sure that it's valuable. We're collecting it at the right place. We're not clicking for the sake of clicks. But one of the important modifications that was made very early in the EMR system that I use, and that's iKnowMed, was making sure that we have COVID screening, testing, COVID status in a structured data field. You know, it's one of those, if we're to learn health outcomes, if we're to learn down the road from this experience, and it's too early really to know what the outcomes experience is going to be from this, we need to know who had COVID, who was tested, when, you know, there are pieces of information that we need to be able to bring forward in the conversation. So I think that in addition to all of the amazing things that happen with telemedicine, we'll talk about that in a minute, but making sure that we're being very thoughtful with the data that we are collecting as part of this process, not only to use and serve our patients today, but to be able to use and serve our patients a year from now or 2 years from now.
Sarah, the point you made about kind of a place to put the data. So it's not just so much that we have EHR, it's a big receptacle, and we had this pandemic and it must be collecting data. It sounds like you're saying we need a place to put the data and know where to find it when we want it. And has that emerged here with regard to COVID?
Absolutely. You know, I think the other thing that is important, and I'm coming from a community oncology lens, is making sure that all of our amazing physicians have the latest up-to-date decision support tools and all of that built into their system. So as new evidence becomes available, that we're incorporating that in real time so that it can be used. It's an important, you know, I think that we have a lot of physicians on this panel. No one loves their EMR. I mean, I don't think anyone's going to go, oh my goodness, I just love it. Want to go give it a great big hug. But you try and make it not be terrible and make sure that it is supporting practice and it is supporting our patients. And I love what Gwen just said about having it being a tool, because ultimately that's, I want to move it away from just being a claims payment device to something that actually is very useful.
Points very well taken. Thank you, Sarah. Jeff, back over to you. How is the EHR emerging or evolving as a tool that will serve the needs that you pursue every day?
Yeah, well, you know, I think even in the first initial comments, you've seen sort of the progress that EHRs have made, at least from their application and use, you know, starting from more of an administrative and efficiency type tool to one that has now been something that enables improved communication between caregivers and patients. But, you know, I think that moving into sort of even maybe the next frontier of things, how can EHRs be used as an additional tool for research, I think is an important component that we did learn a fair amount from in regards to the pandemic as well. You know, trying to understand rapidly evolving information across very large populations, you know, wouldn't have been able to be done in just a formalized, you know, observational registry or a clinical trial or something that may have been more formalized. And it enabled information on more people, you know, that may not have access to those trials or frequently participate at sites where certain trials may be offered. You know, so in some ways it can expand the tent of research a little bit by aggregating data in a way that perhaps wasn't technologically possible years ago. You know, I think the experience of the pandemic probably pointed out some of the limitations that are still there in terms of what an EHR can do as a research tool. But I think, you know, it certainly identified some opportunities, and based on that, it may be worth thinking about, you know, what components of research can an augmented EHR play into the future of, you know, identifying even hypothesis generating questions, which could help design better clinical trials into the future.
So EHR as evolving research tool, you know, it's interesting, Jeff, listening to you comment about that, I'm thinking back on the comment about claims data earlier on. Claims data weren't designed to do research. EHRs weren't designed to do research, but now we're seeing how we can try to mold them and adapt them. And in that case, even link EHRs and claims, I guess, to do even a higher level research. So we are seeing those changes. Thank you for that. Tim, I saw you kind of nodding and grinning and like winking at me a little bit. What do you want to add to that set of observations? And Jenny Cruz, back to you as well.
Yeah, I think thinking beyond the EHR is the thing. So as Sarah said, nobody loves their EHR. I don't love my EHR. But I do love what it allows me to do for the patients. I love the idea of taking it further. I love the idea of going beyond claims data that Jeff talked about. And I think that's what we've got to start thinking about, is what comes next, what comes beyond this, because we can't, a lot of people died here in the United States. We can't lose that, right? So let's take this and move to the next space. That's what I'm excited about coming out of this.
Got it. Well, Jenny, I'm just wondering then, that sets up a question to you. What do we want to be telling the Epics and the Cerners of the world and the other wonderful EHR, EMR vendors? Do we want to convey any messages to them about where to go next?
Yeah, obviously the old gripe continues, which is the interoperability. How do we make this a more friendly system so that we can not only collect the data, put it in discrete fields, but interface with other tools and databases to make that information more usable and friendly? How do we interface it with tools that are helpful for patients when we start thinking about mHealth and remote monitoring? How does the EHR interface with those efforts? We need to be a little bit more open and friendly about interoperability and interconnectivity.
Absolutely. And that does bring us to our next issue, which is, you already mentioned, mHealth, utilization of smartphones, telemedicine, and so forth. Well, Jenny Cruz has already laid down the gauntlet, saying the first thing she wanted to say about that was we got to link them up. Where's the interoperability? And I'm wondering, Sarah, if you thought a little bit about this as well with regard to kind of these as kind of additional new data sources or data streams.
Yeah, I spent a lot of time thinking about this, and it's a great question. It's a great thing for us to be thinking about. I think that on one hand, having your smartphone that you can Skype your physician and have a telemedicine visit in your hand avoids a lot of unnecessary cost to the system. Your people aren't showing up in ERs, they're getting their care triaged. I think those are important things to kind of that have taken us further. I think that we'll see advances as we unpack Cures Act coming up over the next years, and how that's going to impact the patient's rights and mobility with their data to get this in places where they think that it will serve them best. I think that the other thing that this has uncovered, though, is we still have tremendous access and disparities with technology, and how do we continue to make sure that we're being holistic with our patients and with the populations that we serve, when not everyone's going to have the latest iPhone to be able to do a chat, and how can we make sure that when we're providing services, we're not inadvertently leaving out vulnerable populations in that work.
Absolutely. Gwen, I got to go to you next on this, because I know we've spoken on similar topics. mHealth is great. Smartphones are cool. Telemedicine's got great possibilities, but are some patients falling further behind as these technologies are being adopted by other groups of patients who may be better off? What's the take on that, Gwen?
I think absolutely, but I think it's also, there are multiple problems here, and so we have to look at what some of the barriers are. So it's not simply not having the most up-to-date iPhone or Android, but it's also having the divide between rural communities with lack of access, broadband access, to urban communities that often have more access. It is the problem with privacy, and where do you do so if I think of telehealth visits, and we talked about this earlier, I think about two kind of very, very different, but also very real problems. The first one, the positive, is, as we've talked about before, it's sort of like the contemporary version of a house call. You see in somebody's house, you see you see their family around them. You have some sense of the context in which healthcare is being received and provided, and people are promoting their own health. On the other hand, you have people who don't have a place to do a telemedicine visit. Maybe they are working maybe they can't get time off from work and they can't have a healthcare visit there because of their employment barriers. Maybe they, we had a panel about rural health about 6 months ago, and one of the women on the panel had to do the panel from her iPhone in her car because her daughter was doing school in the middle of the day in the middle of a small house. So I think that it elevates both some opportunities for really looking at how we can use telehealth and this other kind of touch point, and that it also really shines a light and elevates some of the barriers in access to care. And when Dr. Lathan talked about access to care as being one of the things that he wanted to really primarily elevate in terms of patients access and equitable access to care, I think telehealth has some of the same problems. So we have to look at some of these themes throughout the various innovations that we're considering.
So Gwen, is this something where we need kind of a national plan to get everybody hooked up to Wi-Fi, make sure we get an Android in everyone's hand? Is it sort of an infrastructure building thing? And or is it something else to make sure that people don't fall further behind as mHealth becomes more standard?
I think it's multifaceted, and I think that it just shows some of the it perpetuates some of the kind of intractable problem. And it also, but it also shows some opportunities. So yes, people need to have access to tools. People need to have access to broadband, but people also need to be able to trust what is happening over their smartphones, over the way that they're accessing health. They have to be able to have a place that is private if they want privacy. They have to be able to bring in their families if they want to bring in their families. So oftentimes, and oftentimes when we think about policy solutions, we think about one solution that we all drive towards without thinking about the context in which we are looking at this solution. So I would really encourage us to look at the context within which we're looking at these policy solutions to make sure that what has never changed will be able to facilitate that change, and that we use them as an opportunity for access.
Yeah.
So I don't think. Yeah, thank you.
No, that's very helpful. And I'm wondering, Jeff, back to the data stuff. So what do you think is the potential then for mHealth and telemedicine to provide augmented data streams to feed research in particular? Is there a great significant potential there, Jeff, as further data sources?
Definitely. I think it wasn't that long ago that we were having similar discussions around things like patient-reported outcomes, which were conducted largely as paper-based surveys. And since that time, those types of methodologies have been able to be deployed electronically, which hopefully can generate more information on more people more rapidly, that will enable modifications as appropriate to be taken to recognize the value of that information and implement it. And even beyond just that level of active participation, there are aspects of mHealth that I think can provide additional data, even in a more passive experience, just without requiring a great deal of effort on behalf of patients to actually contribute some of their data, even by like remote monitoring, whether that be geographic or biological data that can be monitored, simply from, carrying a device around with you, which could provide additional information. I think there's still some challenges around, how to logistically do that and, validate the use of some of those tools, but it really offers a great deal of potential in an entirely different realm than some of the paper-based ancestors of some of this type of work that, has enabled this type of, activity to continue to grow. And, not only can it improve learning about patients' experience, it can help improve them. Things like identifying adverse events that may be occurring earlier when they can be more manageable by alerting a care team, and identifying critical symptoms early on that can be then managed and help patients know and feel more comfortable about do they need to be engaging their care teams, or is this something that they can, manage with information on their own? I hope it provides greater confidence, in the system and the treatments that are being delivered as well.
Yeah, it's a good reminder that it's not only when I'm thinking about putting something into my smartphone or my watch or something, but it's a passive sensor as well, and it can be picking up data all along the way 24/7 in ways that I don't even have to kind of think about along the way. I'm wondering, Jenny Cruz, where you are in Seattle and so forth, what are you kind of seeing on sort of the leading edge here of mHealth and smartphone and telemedicine applications? What do we get to look forward to that you're already seeing?
Yeah, I think that oncology probably hasn't been a leader in this area. There's been a lot more cardiology, dermatology, primary care use of mHealth, but I think there's huge opportunity and obviously a number of private groups that are coming up with products that help us do remote patient monitoring. We live in sort of the land of technology here, where there are certainly groups developing this work. I think the importance really is getting back to the interoperability and having a way to interface that with the EHRs so that it's very usable for the medical team. A lot of times, the efforts around pros fall on the shoulders of nurses, actually, who are the first responders to the patient's symptom algorithms. So if we can automate that as well, I think it's a workforce benefit to have some artificial intelligence help us manage those algorithms, incorporate patients being able to do self-management, but then at a threshold of need that gets escalated to a healthcare team.
Wow, you mentioned AI here, Jenny Cruz. Can you give us a little kind of peek into AI applications via these modalities that have some upside, whether in oncology or somewhere else? Tell us a little bit more about the AI, if you would.
Yeah, so there have been some presentations and papers published in this area looking, for example, at pain management and incorporating a push questionnaire to patients. And then based on their responses, there's an AI algorithm to the level of intervention required. If it's self-intervention, there are educational materials and reminders that get sent to patients. If it requires a more higher level of expertise or intervention by a professional team, it goes to the medical team, the nurses, et cetera, to manage. So that's just one example of how AI can help sort out the degree of triaging that's required to address patients' needs.
Great explanation. Thank you very much, Jenny. Tim Kubal, so with regard to how you practice medicine in your particular specialty and subspecialty, are you seeing true advantages now in mHealth and telemedicine, smartphones and so forth? Is it making a difference yet for real?
Yeah. I mean, no question. You could divide this into the PRO space or for me, the telemedicine space. And because we're short on time, let me just speak to my telemedicine experience. When the pandemic started, my patients stopped showing up, but then they all started showing up again on telemedicine. So at this point here in the state of Florida, where we're not even reporting numbers, as a hematologist, 50% of my patients are telemedicine still. And they are even ones that live down the street from it. They have their labs done locally. They're seen the next day via telemedicine. They don't have to come in. So the other thing that's nice, there are patients I'm managing in hundreds of miles away, hours and hours away, for conditions where I'm probably the person who manages most of it in the state. And I can manage those people with local labs and interventions through their doctors. And so you can get that, it's not public-private partnership, but you know what I mean. It's the private oncologist locally with the academic oncologist through telemedicine, and it's great. And then from a research standpoint, just a statement on telemedicine, things like that. Jeff, you talk about trials. I've got a patient who's on a PNH trial up at the NIH. When the pandemic started, they said, we're going to close the trial, and she said, I'm doing great. And so what they ended up doing was saying, we will ship you the drugs. Moffitt can do the blood draws. So we did the blood draws, and the symptom assessment was done via the phone with the team. And she continued the drug. She continues on the trial to this day. It's effective. It's raised her hemoglobin 3 points. She feels better than she's ever felt. And it's an opportunity for everybody in the entire United States to get on an NIH trial without having to go to the NIH every time to pick up their pills every 3 weeks. And the NIH says to you, Cliff, they say, well, we'll fly you here. Well, maybe you don't have to. So, I mean, it really has changed this woman's life. It's changed the life of the people that I can care for in this partnership with their oncologists, and still half of my patients. And I think that may only expand over time as a blood specialist.
But you're talking now, Tim, I think you've kind of synthesized a few previous statements into, well, actually, we are reorganizing how we communicate and deliver healthcare now, including in hematology. The network connections, the nodes and so forth, they're different. They're reconfiguring somewhat in a way that sounds like you think is going to be permanent, lasting.
Yeah, I think so. It's better for the patient. And
Yeah.
if it takes me 2 or 3% more time, but it's 40% better for the patient, I'm more than happy to spend that. My entire life is spent trying to see these people do well. And so, yeah, I want to see the nodes reorganized for the benefit of the patient.
Sarah, are you buying into this reorganization here?
100%, 1000%. This is one thing that I desperately hope we hold on to, in that I heard I spent some time with some patients this last weekend, and one said that she was signed up for a trial in Boston. She lives in Tennessee, and the trial got shut down because now they said you got to come in person, where it was telemedicine before. So I want to make sure that when we have that possibility, and I know I'm not going to say it's going to work in every case, but where we can have that telemedicine visit and that decentralization of trials, and use the network we have to make sure that, you know, the trial is the first choice, not the last chance, and all of that good stuff to make sure that patients are getting to it. I think that that's important, but I think it underlines something really important too. Jeff started kind of on this path, and that we're collecting all of these data from all of this place. Now we got to analyze it, and we got to do something meaningful with it. And that's going to come from an increased use and standardization, and the Friends work on standardizing and trying to come up with real world endpoints, and using the data to make sure that we're thinking about and talking about it the same ways. And the FDA's recent guidance on what's a real PRO, because it's easy to start collecting stuff and it not being meaningful. So I think that these two things go together, but we got to hold on to that as we continue kind of back into normal.
Speaking of that, normal and real world, Jeff Allen, moving to real world data, real-time analytics, you mentioned the COVID-19 Evidence Accelerator. Can you tell us about what that has done to the world of RWD, RWE, and do you see it affecting oncology, cancer care, cancer research in particular? Jeff?
Yeah, you know, I think it has hopefully improved the transparency and elevated some of the methodology that has been applied to various different data sources, and maybe even increased the understanding of very different data sources and what sources are capable of and what other sources are not capable of. And you know, that's obviously an important component of using real world data as a research tool. I think it was unique in terms of creating kind of a community that could come together and you know, really share initial observations, share learnings, bounce protocols off other experts that they may not have been able to have regular access to, and improve the research at the you know, at the end of the day and moving forward. You know, I do think there's absolutely ways that experience can inform other therapeutic areas. It's not unique to COVID-19. It may have been necessary for COVID-19, given sort of the rapid evolving information front and the need for rapidly evolving data. You know, I think there were a lot of organizations, government, private, public, that were having to make decisions in the circumstances of COVID-19 on oftentimes incomplete information given the enormity of the circumstances. And so that was really the goal. How could a group of various different stakeholders come together, share the information that they have, and try and leverage that? it was really built on the experience of the oncology community, frankly, you know, where a number of different organizations that have access to large amounts of data, are experts in using that data, you know, had come together over the last couple of years to try and sort of pressure test various aspects together, you know, working with their individual data sets to help advance the field. And we tried to sort of apply that same type of approach into COVID-19 and you know, expand the involvement of others. So I think that's absolutely applicable and will be necessary into the future in order to, you know, continue to think about the evolution of data and how it can be appropriately used.
So Jeff, then did the pandemic force us, as we started here before, did it force us to be more open-minded about getting stuff done faster, with fewer requirements, less bureaucracy, and just let's move on in a shorter time frame? Was that accomplished as a result of this? And can we retain that for future research in oncology and elsewhere?
I think there were certainly a lot of things that that became necessary under the confines of the pandemic that hopefully we can retain. And they may be big and they may seem smaller, you know, even things like very nuanced things about like you know, adjustments to IRB review or pre-planning things like modifications to trial protocols, you know, that could help improve efficiencies into the future. You know, I think particularly in the early months of the pandemic, you saw a lot of people, no matter what their vantage point, wanting to do anything that they absolutely could to help in that situation. And I think that is a hard thing to sustain, but I think that we have, you know, learned that you can address enormous situations by working well together. And I hope that is able to continue. And, you know, the oncology community has done that well in some circumstances and perhaps not as well in others. And so hopefully, you know, we'll be able to leverage that type of collaborative approach into cancer research into the future.
Yeah, there was a rush for everyone to try to do what they could do. Jenny Cruz, are you seeing this kind of as a way to contribute to the advancement of use of real world data and related analytics?
Absolutely. You know, as I listened to Jeff describe that, I think that there's a great example of the benefit of coming together in that collaboration and real world data in the CCC19 database, which is the COVID-19 and Cancer Consortium, which started at the very beginning of the pandemic, was a global effort to collect outcomes information on cancer patients who had tested positive for COVID-19. And the remarkable thing is how quickly we were able to get learnings from that. We had information that was presented in early June at ASCO from that consortium. So just over a matter of several months, we had real world data that made a difference in how oncologists and communities were managing cancer patients. So that has such potential if we can keep that momentum going forward with these real world data opportunities. Think of the answers we can get to so many questions that are burning in oncology now.
So Jenny, then you're suggesting then that not only were we getting better and faster at collecting real world data and synthesizing it into RWE, but it sounds like we also were able to feed it back to the clinical decision makers, patients. Can you say a little bit more about how we did that well?
Yeah, I think the turnaround time, people were, you know, there was a burning platform. People were heavily motivated to get information. We were all hungry to know how to best treat our patients. And so the analysis of that data and the rapid dissemination back through multiple means, you know, meetings, online publications, et cetera, was really impressive.
Got it. Thank you. Sarah, I want to just hear from you how this has transformed your work in real world evidence and analytics. And I want to set up Gwen for a reaction to saying, yeah, okay, but here's how it's affected patients or not. Sarah?
Yeah, a couple of things. One, I think that this has increased the velocity, if you will, of using data, thinking about data, and this exposed the entirety of our population to trials, what a trial was, what real world data were, you know, and so I think that visibility was really important, and we really feel that. I think the other piece of it is it's amazing how much cooperation and how much we can advance when everyone's participating and playing well together with a singular focus. So I know that there's been articles on what if we have warp speed for cancer? I mean, but like, what if we did that? You know, it's like we definitely had a public health crisis, but cancer is also a public health crisis. So it's what if we organize differently around that?
Points very well taken. So Gwen, does it actually make a difference to the patient experience, the patient outcomes? Are we seeing improvements accordingly?
So I want to take a little step back and inject a kind of note of caution, and also refer to the prior panel, and what Ms. Brooks-Coley said about polling in terms of how people felt about screening and monitoring, and whether that actually would lead to good care or whether that would lead to them receiving lesser care. And it's something that we have found as well. We were looking at it particularly in terms of cost of care, but people who were already at a underinsured or under-resourced were very concerned about being screened or being monitored, because they felt that was a way that was a barrier to care, that would keep them from care. So I want to just inject that note of caution, and also reinforce what I said before, which is that we have to take this back and look at the context within which this is happening. And we also, I would like to think about marrying this conversation about public health crisis with a whole societal crisis, where we are actually being able to talk about things. People are talking about racism. People are talking about a just healthcare system. So if we are to use telemedicine, if we are to use real world evidence, if we are to use all of these things that should be of great benefit and should help outcomes for patients, we have to make sure that we can do that equitably. We have to make sure that we understand what the barriers are. I mean, there are many people who do not want to be monitored for very good reasons. There are very many people who, there are different kinds of screening that people can't do for different reasons, whether it's because they think it's going to keep them from care, or whether they think it's because it's going to uncover a disease that they can't treat. So I think that the impact of real world evidence and all of this evidence that we're gathering is only as good as the representation of the people who are impacted by these diseases. And this has been an ongoing and intractable problem. And I think that is really where I would focus if I was thinking about how to look at the impact of telemedicine, EHRs, all of mHealth going forward. Cliff, you're holding your glasses.
Well, I'm focusing.
I thought maybe I were just like, but that's where I would really start, because we all want a just healthcare system, and that we can't have a just healthcare system unless we look at the context and we look at access and barriers to care.
Absolutely. I mean, caution well recognized, but we haven't acted on it sufficiently. And I'm just, something to think about is, are we using real world data and evidence and analytics to actually close these gaps? We're enhancing care for a lot of people. We're doing better at it, maybe even improving outcomes, but we may still be leaving folks behind. Tim Kubal, back to you. Is this coming back to serve you and your patients? We were doing stuff better, faster, more efficiently. We're collecting the data. We're doing some cool modeling. And according to Jenny Cruz, it is being fed back into practice. Are you seeing it? Are you feeling it?
Yeah, and it is getting there faster. And I think, Cliff, what you said earlier about maybe disparities, I think the tide is rising for everybody, but the tide is rising more for some people, right? So somebody who lives in a city with high-speed internet, who's got a great relationship, their ability to give us data and get back high-quality care is exploding. Somebody else, maybe the tide rises because they can get me from their car and not have to take a day off of work. Great. But their data doesn't necessarily go in the same way, and they don't get the same quality of outcomes that comes from here. And so for me, yes, they're absolutely seeing it. Every patient has seen the tide rise because of what's happened here. Some have seen it rise more. And I really, really want us to get to a point, at Gwen, as you said, about a just system. The faster that it rises for everybody, the faster it rises for everybody else. right?
Aha.
So Jeff, as you said, this data it comes in so fast. Jenny's using AI to synthesize it. I'm putting it in the bedside. Cliff, we were publishing papers in a week that would have taken a year before.
Right. Saw that quicker
and
turnaround.
It is like lightning, but the faster that we get everybody to rise at the same speed, the faster everyone rises.
So the rising tide is lifting all boats, but not at the same rate. And that can be bothersome. Okay, closing question. I'll ask you to answer it just like less than a minute, a sentence or two at most. And this is going to be putting yourself in the future with a look back question. Here's what I mean. So this is what, 2021 now. Let's say we're in 2026 or even later, and we look back and say, good gosh, that pandemic, COVID-19, 2020, and early 2021, we did make some important advances that affected cancer care delivery and innovation. What was the most important thing that transpired as a result of the COVID pandemic in oncology that will be lasting and have a long-term effect? What's the best thing that is coming out of this thing that we may not perfectly see now, but we're certainly going to see 5 or 10 years from now? Sarah, what's your one thing? Just a sentence or so.
I think we found that when we work together, we can go really fast. And I think that we need to, like I said a second ago, we need to hold on to that. And I think that we'll look back in the future of how fast we really went and what we learned from working together on a single goal.
I hear you on that. Thank you. Dr. Cruz, what do you think we're going to look at fondly 5 or 10 years from now?
I'm going to say we walked the walk and proved that we could take care to the patients where they are.
Perfect. Thank you very much. Jeff Allen, what's it going to look like 5 to 10? You'll say, gosh, we really pulled off something cool then. What was it?
Yeah, I think, as a community, we really learned that barriers don't need to be avoided. They can simply be taken down, and that is possible. And that happened through a variety of different examples throughout the pandemic. And I hope we stop avoiding all the barriers and work on ways of addressing them and taking them down.
You got it. Tear down this wall. I'm transplanting a note. That was politics, but in any case, Gwen Darian, what will we say we did really well at that time?
I think that we'll look back and look at how we use telehealth and medicine as a patient empowerment tool, and how we recentered the delivery of healthcare on the patient's home, on the patient's community, and that we'll come up with a hybrid system, because earlier they talked about patient touches. So I was actually thinking about healing touch, but you can have a healing touch that's in person and you can have a healing touch that's virtual.
Aha. Perfect. Thank you. And the empowerment thing very much as well. Points well taken, Gwen. Well, Dr. Kubal, Tim Kubal, I'm thinking that 5 or 10 years from now, you're going to be looking back on mid-June as remarkable for a few reasons, one of which just occurred. Congratulations. But apart from that, and maybe even secondary to it, you'll look back and say, that pandemic really made us accomplish something special, and this is what it was.
So what I want everybody to think about here, there's something called Parkinson's Law. And Parkinson's Law, if you look it up, is work fills the space allotted for it. And in COVID, the space allotted for it was now. I'm wearing a mask and I'm out of toilet paper. Hurry up and get me a vaccine. I'd like to see us apply the same law to cancer care, right? So the time to fix cancer, to think about this, the speed of this, the velocity of this, the time is now. And so I want us to recognize the value of Parkinson's Law, not just in the creation of vaccines, but in providing cures to the cancer patients today and in the future.
You got it. We want it now, and we can make it happen. Thank you, Tim.
We can.
Well, thank you, Tim Kubal, Jeff Allen, Jenny Cruz, Sarah Allward, Gwen Darian. We look back, we look forward, and you did a great job at highlighting what we have gleaned from this pandemic on the upside as well as the downside, and calling our attention to what we need to do next. So thank you all very, very much. I love this panel. Wish we could go on. Thank you so much.
Thank you.
All right. We're going to move on now for a special session now. We're right on time at 12:30 Eastern time. And we're going to take a look at road mapping to more equitable care in Medicaid and Medicare. We're going to hear especially from a special visitor today. And I'm going to turn it back over to Bob Carlson to make that introduction.
A big thank you to the two panels for such informative discussions. We appreciate your sharing your thoughts and expertise with us today. It is my distinct pleasure to introduce our afternoon keynote speaker, Dr. LaShawn McKeever. Dr. McKeever serves as the Director of the Office of Minority Health at the Centers for Medicare and Medicaid Services. In her role, Dr. McKeever is the Principal Advisor to the Agency on the Needs of Minority Populations, including racial and ethnic minorities, people with disabilities, members of the lesbian, gay, bisexual, and transgender community, individuals with limited English proficiency, and rural populations. She also provides expertise to CMS on minority health and health disparities and provides recommendations on how to address them. Before joining CMS, Dr. McKeever led government affairs and advocacy efforts at the American Diabetes Association as Vice President of Public Policy and Strategic Alliances, and later as its Senior Vice President of Government Affairs and Advocacy. Dr. McKeever has also served as a research fellow for the Congressional Black Caucus Center for Policy Analysis and Research, and as a program director at the Baltimore City Health Department. Dr. McKeever earned a medical degree in international health and medicine through the Medical School for International Health in collaboration with Columbia University's Medical Center, and a master's degree in public health from the Johns Hopkins University Bloomberg School of Public Health. We welcome Dr. McKeever today as she shares with us the role of her office in advancing equitable care in Medicaid and Medicare, and some opportunities for involvement of the oncology community. Dr. McKeever, welcome.
Thank you, Dr. Carlson, for that introduction, and good afternoon and good morning to others. I'm really excited to be a part of this discussion that the National Comprehensive Cancer Network is engaging in today. And I was able to hear some of the previous comments, and I think, this conversation really is at the center of what's happening in many different areas across the country. So as mentioned, my name is Dr. LaShawn McKeever, and I'm the newest director of the Office of Minority Health at the Centers for Medicare and Medicaid Services. I've been honored over my nearly 2 decades of my career to focus on the needs excuse me, of underserved populations. And as many of you know, this includes those impacted by cancer. I joined CMS last fall after, as noted, working on behalf of people with diabetes. And I consider this a tremendous opportunity to improve the lives of our beneficiaries and consumers, those that we serve. So as stated, there is a rich conversation that's already taken place today. And I've been asked to share with you what is the new normal for the CMS Office of Minority Health. And one of the last few comments that I heard, I think, was made by Dr. Kubal, who said the tide is rising, but it's not rising the same from everyone. And then I also heard a comment about what happens next will take us all working together. And so in these next few moments, I'll just share with you the work that's currently underway in our office, how it's being shaped by this current environment, and what are the opportunities ahead for CMS in creating a roadmap to equity in our health insurance programs, and how we can partner together to do that. Next slide. Okay, thank you. So I'll just start with a little bit of history about our office. We were created over a decade ago out of the Affordable Care Act, along with 5 other offices in HHS, to join the HHS Office of Minority Health and the National Institute of Minority Health and Health Disparities, which was promoted to an institute under the law. Next slide. The mission of our office is to lead the advancement and integration of health equity in the development, evaluation, and implementation of CMS's policies, programs, and partnerships. And our vision as an office is to ensure that all those served by CMS achieve their highest level of health and well-being, and we have eliminated disparities in healthcare quality and access. Next slide. This slide here talks about our function within CMS. So our office serves as the principal advisor and coordinator to the agency for the special needs of minority and disadvantaged populations. We provide leadership, vision, and direction to address CMS minority health and health disparities goals. We participate in the formulation of goals, policies, and strategies within the agency. We implement activities to monitor CMS health equity programs and share resources. We consult with federal agencies and external organizations such as those gathered across the country today here to address health equity. And within our office, we have two primary groups that I'll just briefly tell you a little bit about. Next slide. So a core function of our office is to lead the development of an agency-wide data collection infrastructure for minority health activities and initiatives. And we monitor the impact of agency programs. So this is accomplished through our data policy and analytics group at CMS. We work with the different components across the agency on data-related efforts. We work with appropriate components to facilitate access to and analysis of CMS data to support research efforts to better understand the causes of and design effective programs to reduce health disparities and improve quality of care for vulnerable populations. And we also work with researchers external to the agency and with other stakeholders to raise awareness of study findings. In addition, we work to improve the completeness of race and ethnicity data in Medicaid and CHIP programs as an example. So our Center for Medicaid and CHIP Services is imputing race and ethnicity data using geocoding and census data. This data from census will be specific for the Medicaid and CHIP population. These are some of the efforts underway, but we work across the agency to ensure the completeness of this data. In addition, we conduct environmental scans to identify data needs to facilitate the measurement of health disparities, their associated costs, and the identification of potential solutions, as well as the data needed to evaluate the impact of programs and policies on health and access to care for vulnerable populations and on health disparities. We cultivate partnerships, both within the federal government, with state and local governments, with universities, with research institutions, and as I said, with other components to reduce health disparities and improve minority health. And we serve as a feedback channel for research and data concerns. And then listed here are some of the products that our office produces and things that I'll be talking a little bit about as significant tools for the journey, the health equity journey ahead. Next slide. So our second office, the Program Alignment and Partner Engagement Group, this group works with other components within CMS and partners to develop programs and initiatives that support healthcare providers who practice in other underserved geographic regions and whose patient mix contains a disproportionate share of minority and other underserved populations. It also serves as an internal advocate for the needs of vulnerable population and provides seminars and technical guidance to CMS leadership and staff to facilitate a better understanding of health disparities and a better understanding of how CMS policies and programs can reduce them. Our team collaborates with internal and external partners to promote awareness and understanding of our programs and initiatives and to identify the needs of vulnerable populations to provide feedback mechanisms for these populations and stakeholders regarding the implementation of CMS's programs and initiatives. We facilitate, manage, coordinate grants, contracts, and other types of agreements to related to initiatives impacting vulnerable populations and health disparities. So again, here are some of the resources that our office provides that I'll be sharing a little later. Next slide. So hopefully that information provides you with a helpful background on our office and our role in driving equity within CMS. I do want to take a few moments to share with you some perspective of how this work is currently being shaped in this new normal. So what is the current environment of health equity at CMS? Listed here on this slide are two of President Biden's executive orders that I want to speak about in more detail that establish equity as a defining part of this administration and gives clear guidance to federal agencies that equity must be included in all parts of our work. There are several executive orders, but the two here specifically talk about ensuring an equitable pandemic response and recovery, and also advancing racial equity and support for underserved communities through the federal government. We do have several resources for those who are working with underserved populations during the pandemic. And so I hope that you'll visit our website, which I'll have at the end of the presentation, for those resources that are in different languages. But more importantly, there's been a tremendous effort underway during the pandemic. And as it states, focusing on the recovery, what happens next? And we've heard from many about the importance of telehealth. I heard that mentioned in the previous discussion, and how it has benefited many during the pandemic, as well as some of the challenges that we need to think about moving ahead as a healthcare system, and particularly CMS's role in that. But for purposes of the discussion today, I want to focus on the Executive Order 13985, the Advancing Racial Equity and Support for Underserved Communities through the federal government. Next slide. So on this slide here, you'll see a summary of what's entailed here, but overall, it really lays out a systemic approach to address inequities. This includes embedding fairness within the decision-making part of all federal government agencies, and it takes a very comprehensive approach to doing so. It lays out underserved communities as those adversely affected by persistent poverty and inequality, a focus on tribal communities, people of color, and otherwise historically marginalized populations. Next slide. Listed here are some of the specific sections that speak to our current work. So for example, establishing the implementation of policies across the federal government that address racial equity and issues faced by persons in underserved communities as one example. Another here talks about offers methods to assess equity through data, discussing barriers to benefits and potential for new policy. So of course, with CMS being one of the largest payers of healthcare in the world, this is an important executive order for our work ahead. Some of our key activities that are currently underway across the agency really speak to our holistic approach to equity. So we're working across the agency to take a critical look at what we are doing within CMS related to equity, and also thinking about our equity plan. So I don't know if you all are familiar with our Medicare equity plan, which we recently released a progress report in January that talks about some of the strategies we're looking at and applying to the Medicare program. But in this context, we're thinking about what happens next with this plan as it relates to the directives around a holistic approach to equity. As well as we're engaging with our stakeholders from different sectors, such as those who are gathered here today, and revisiting our previous equity work so that we can better understand what are the needs of the populations that we're serving. Next slide. So I talked about our data policy and analysis group that is currently working to address critical issues of data completeness. And we will continue to do this important work in collaboration with other internal and external stakeholders on this issue. As noted previously about the importance of different types of data and how we use them and how we think about them in the future. If we don't understand, I think COVID has taught us if we don't have the right data, it's difficult for us to drive solutions that will impact all of those who are a part of, who have been negatively impacted. So as an agency, we're looking at that critically. As I said, these executive orders really take a whole government approach to equity, and it provides a unique opportunity for our agency to impact underserved populations and to leverage key tools that we have within CMS that can help drive equity within the healthcare system. What I'll do in these next few slides is tell you about some of the tools that we have that can help those who are working with populations that are impacted by cancer in any form. Next slide. So as I just mentioned about data, I'll start with this tool here. So in order to address chronic conditions with an equity lens, our office created this interactive Mapping Medicare Disparities tool. And this tool provides a granular lens in chronic conditions by identifying areas of disparities between subgroups of Medicare populations. So for example, different racial and ethnic groups, age and sex, in health outcomes, utilization, and spending. It is an excellent starting point to understand and investigate geographic and racial and ethnic differences in health outcomes. And this information may be used to inform policy decisions and to target populations in geographies for potential interventions. So you can view this at a population view, but also you can look at this from a hospital view through a quality of care and cost of care lens at the county level. Next slide. We have several data tools as as I noted before. So we have what are called data highlights, and our data highlights present national and regional data on Medicare populations. And this really is to provide overviews of specific public health issues, and it gives quantitative and qualitative analysis of our data and explain how these findings support or relate to CMS's or HHS's policy initiatives. Next slide. In addition to the data highlights, we have data snapshots, and these provide high-level information on different chronic conditions and the impact on minority groups. Next slide. I have here just a few slides talking about cancer trends within the Medicare population. And this is using data from our chronic condition data warehouse. So here are some, some things that I'll share with you regarding cancer trends among Medicare fee-for-service beneficiaries. So one of the things that we found is that the rate of breast cancer in females has slightly risen over time. So from about 4.9% in 2009 to 6% in 2008. We found that the rate of prostate cancer has fluctuated somewhat for our beneficiaries from a high of 7.5% in 2011 to a low of 7% in 2014 to 7.3% in 2018. We also saw a small gradual increase over time in endometrial cancer, and the rates of lung and colorectal cancer have been relatively stable over time. Next slide. Here's a look at, again, from, this was taken from our Mapping Medicare Disparities tool, and it is looking at prostate cancer among male Medicare beneficiaries by race and ethnicity in 2019. So as you can see here, Black and or African Americans have a higher prevalence compared to the other groups represented on the slide. Next slide. Likewise, taken from our Mapping Medicare Disparities tool, you can use that to look at, as I said, you can look at different populations in different ways. So this is looking at prevalence of breast cancer among female Medicare fee-for-service beneficiaries by race and ethnicity, and you can see how different populations are impacted here. Next slide. And so again, here is information regarding breast cancer screening. So if you haven't had a chance to leverage our tool, I do encourage you to take a look at that tool because it provides really helpful information. Next slide. So as I'm sure many of you know, despite the many advancements achieved in cancer prevention, detection, and treatment, there are groups who have not had the same improvement across the care continuum. So racial and ethnic minorities tend to experience more cancers than compared to other populations, and communities that are medically underserved lack access to sufficient cancer care due to the social determinants of health. And so, for example, we know that for some underserved populations, they may live in a food desert, a neighborhood that has limited public transportation, or an area that has higher air pollution. And all of these factors can increase the burden of disease and create additional barriers when accessing preventive and treatment services. So this is a part, we do in our work as well, focus on the social determinants of health because we know the importance of this for our populations. Next slide. I wanted to share with you all a tool that we have within CMS OMH that we use with our external partners and also internal to CMS. And this is called our CMS Disparities Impact Statement. This is something that we launched in 2016, and the implementation of this tool is supported by our Health Equity Technical Assistance Program. This tool can help you embed health equity into, for example, cancer treatment initiatives. Next slide. And since a one size does not fit all, as I mentioned, we have a health equity TA assistance program, and it offers one-on-one technical assistance and consults to help with stakeholders who are looking to reduce health disparities. So we work with healthcare systems of all sizes, different types of organizations. It's really a wide range of stakeholders that we support through this program. This is a very flexible type of technical assistance that we offer, and any organization can email us for a single call for help on a disparities related question, for example. If they lack guidance or resource on how to collect or analyze data, how to begin a cancer treatment quality improvement activity, or interventions for a particular population or type of provider, or how to create a health equity governance structure. So you can see that there's a breadth of activities that we provide support for, and we are certainly willing to support those who are working in this space as well. And so you can request that technical assistance from our office through our Health Equity TA at cms.gov. Next slide. I'll just share quickly some tools. I have an eye on time. I know we started on time, so I want to make sure we end on time as well. So from a language access perspective, we know that language access and communication access is an important part of health equity and cancer treatment. And so we have materials that have been developed to help you develop language access plans, and also to provide guidance on improving communication access for people with sensory disabilities. This is important because we know that populations with disabilities and people with limited English proficiency may face barriers with access to care, including cancer treatment. Next slide. And here is information on that we developed for beneficiaries who have disabilities and need access to care. This resource describes ways to collaborate with healthcare organizations and providers before, during, and after a medical appointment. And it's a helpful tool for people with disabilities because people may, as I said, face various barriers. And this describes the rights of people with disabilities and how they can file a discrimination complaint if a healthcare organization denies medical care or services because of a patient's disability. And we have this resource in Spanish, Arabic, Chinese, Haitian, Creole, Korean, Russian, Vietnamese, and Braille. Next slide. We have what's called the Connected to Care campaign, and this is aimed to help Medicare beneficiaries and their providers to understand chronic care management services, and we have educational materials about the services to assist. As you can see on the slide, there are requirements for who in Medicare is eligible for the 4 CCM services. So this information and other information about what to expect is included on our website along with other resources. So I think what I will do next is just quickly go through these last final slides, because I do want to tell you about a model underway at our Innovation Center. So I mentioned the Connected to Care slide. Next slide. We have resources for partner and healthcare professionals related to our Connected to Care initiative. Next slide. We have additional patient resources here and some videos as noted. Next slide. And the last piece that I'll talk about relative to resources that we have is our From Coverage to Care Health Literacy Initiative that's focused on increasing consumer connection to care and eventually bettering healthcare outcomes. So I encourage you to leverage this tool for your patient populations. It is one of our most widely used tools and downloaded tools. So this just making you aware of our From Coverage to Care campaign. Next slide. So the very last piece that I'll talk to you about is to share some exciting work with you that's underway within our Center for Medicare and Medicaid Innovation. So the purpose of the center, as I'm sure many of you know, is to test innovative payment and service delivery models to reduce program expenditures while preserving or enhancing the quality of care furnished to individuals. Next slide. Currently, we have a model underway, our oncology care model. And this is a 6-year voluntary model to improve care and reduce costs. And it's running through June 30th of 2022. And there are key opportunities to improve various aspects of care for patients, particularly those who receive chemotherapy, including reducing acute care utilization in the hospital and/or emergency room setting, improving end of life care, better incorporation of value and evidence in drug prescribing, and also incorporation of the whole patient in the care approach, such as identification and treatment of mental health comorbidities, addressing the social determinants of health, as we noted, is an important part of this work, such as nutrition, transportation concerns, and improved care coordination. Next slide. Throughout the entirety of the implementation of this model, we've heard a number of encouraging anecdotes from our participants. Like this model enables them to do what they've always wanted to do by having the MEOS payment to support additional services not traditionally covered by Medicare, that they've improved care coordination, symptom and pain management, recognized depression and distress, address financial toxicity, improve communication, and address health-related social needs. Next slide. To date, the evaluation has found that the quality of care has been minimum maintained, with patients in both the OCM and comparison group reporting high satisfaction with the care experiences. So far, the OCM does not appear to have reduced disparities, but it also has not exacerbated them. And so as we look to the future in alternative payment models for oncology, we are considering how best to build the OCM experience and incentivize model participants to address and improve health equity. Next slide. So you can find more information here at innovation.cms.gov/innovation models oncology care. Final slide. Okay, so just in closing, I just wanted to say again and reiterate the importance of the conversation today. And I'd like to thank the National Comprehensive Cancer Network for the invitation. As our office looks ahead to a new normal in equity, we're excited to share the wealth of resources that I talked about today that we hope will aid others on their path to equity. And I certainly look forward to partnering with you all on this journey. This is incredibly important work. This is an incredibly important time. And it's with partners like those represented here that we will be able to address the critical needs of populations that I think all of us have recognized. COVID has made absolutely clear we can't continue down the current path. We have to do something different, and we have to work together to get there. So with that, last slide just has our information on how to contact us, and I'm happy to answer any questions. Thank you.
Thank you very, very much, Dr. McKeever. And I got to say, just listening to you describe what the Office of Minority Health is doing in CMS and the various activities, one has to wonder why it has taken this long to get here, to set up the office and to enable it to do the kinds of things that you described so well, with greater breadth than I thought even the office was doing. So you're doing more, better things than I think I've certainly had realized to date. Just leading up, setting up a question that actually was discussed in our previous panels. And this has to do with things beyond CMS, even beyond HHS. We're interested in hearing how your office, the Office of Minority Health and CMS, might be able to work with, let's say, the Department of Transportation on those transportation issues, or maybe even the Federal Communications Commission on broadband access. Do you have the ability to kind of go beyond your own department to try to solve some of those issues?
Thank you for that question, Dr. Goodman. And I'll just also, say, thank you for, acknowledging the work of the office. We still are a new office within CMS, and I've been sort of positioning this discussion as we've had 10 years of being, as establishing a path and a role within the office. And now I'm coming in for the next decade of health equity, which we are really on the precipice of something incredible. So thank you for those words. What you spoke to about collaboration is not just key in the private sector, but it is key in the public health, in the federal sectors that are addressing these issues. And that all of the departments that you described really talk about the social determinants. It points to how will we address things like the social determinants of health. The healthcare system has a role in eliminating disparities, but we can't do it alone. So CMS, we have a role in the healthcare system, but we can't do it alone. So we are working with other federal agencies to address issues of our populations. And it's absolutely critical that we build and strengthen these types of partnerships to do that work ahead.
Great, thank you very much. It just seems that in order to solve these issues and close the disparities and so forth, we have to get out of our silos. Even as big a silo as CMS is, we need to reach even further beyond. On behalf of the folks in the oncology, the cancer care community, when we see issues that are of concern to us about minority health, how do we start thinking about where and how to reach out? Do we start with your office? Is there a point of contact? How do we sort of kind of get engaged to try to sort of get triage to the right place that can help us out along those lines, Dr. McKeever?
So our office is the central coordinator and integrator of health equity. So if there's anyone that's working on something related to vulnerable populations and how it interfaces with CMS, you can always start with our office. We can get you to the right, programmatic space in that regard, but also we represent the voices of these populations. And I have here a number of ways that you can engage with our office. We are launching stakeholder roundtables this year. So for Pride Month, we launched our LGBTQ+ roundtable with providers and stakeholders from all across the country. We plan to do this on a more regular basis. Having come from the patient advocacy space, there's the saying, there's nothing about us without us. And we're representing populations who have very different experiences within the healthcare system. So we want to hear from you. And you can sign up for our listserv to hear about opportunities on how to engage. But I would welcome the oncology community to engage with us. These are complicated conditions to manage. And for people who are living, who have different types of barriers to accessing care, it becomes even more complicated. And so our office is here to be a voice of these needs and to help drive and ensure our policies eliminate barriers. And certainly, we don't want to do anything to drive any barriers. So we're here for that purpose.
Well, thank you. And if you don't mind, just a closing question for you, Dr. McKeever, and that is, can you draw on your own personal experience, sort of your odyssey to get to where you are now, for any lessons that we might learn insofar as advancing this particular cause in the cancer care community? Just looking back, are there any gems of wisdom or insight that you can share with us that might help us do our work?
That's a wonderful question. I would encourage you to work with non-traditional partners to get there. Look around your table and see who's missing. I've had a long career in public health, and one of my very first assignments was really building a social determinants of health model for the city of Baltimore that addressed youth violence prevention. And we looked around our table and there were some key partners missing. But as we began to fill that table with the other partners who we traditionally had not worked with in this space as the health department at that time, we realized that the solutions became richer. the reach became broader and our understanding became deeper. And so with understanding, with knowledge comes understanding, and with understanding, that helps to drive the solutions that are meaningful to the populations that we're all trying to serve. So I just encourage you, as an oncology, for years, we were guilty of the disparities community, only talking to the disparities community. And now there's so many others at our table, and that has been transformative to us, broadening our scope of work. So I encourage you all to broaden your circle of partners, because that is how we will get there together.
Well, thank you. I just recorded that myself for posterity. Non-traditional partners, you must ask, who is missing?
Mm-hmm.
Well, Dr. McKeever, we think you're the right person at the right place at the right time. We're so appreciative to have you here and to share with us the information about the Office of Minority Health in CMS. Like we said, it was late in coming, but we're glad we're on the case now and doing all these programs. We hope to have you back for future programs if you don't mind. And best of luck to you. And if you do well, we'll all do well. Thank you so much, Dr. McKeever. Great to have you.
Thank you, Dr. Goodman, and enjoy the rest of the day today. Thank you all.
We will. Indeed, we will. Thank you all. Okay. Well, we're going to now move to our third panel here. And gosh, what a great setup from Dr. LaShawn McKeever for this. Well, guess what it's about? Creating a more equitable care delivery system. I think our previous two panels, Dr. McKeever, and even the data stuff that Marie Aitken shared with us early on, helped set us up for a fine discussion here. And I'm going to ask each of our three distinguished panelists to introduce themselves, kind of with whom are they and how is it they find, what is about their job, your role, that places you in a panel with a title such as this. Shanta Chambers.
So good afternoon, Cliff. And thank you to NCCN for the invitation today. As Cliff mentioned, I'm Shanta Chambers, and I lead PAF's health equity work that's really designed to better understand and respond to factors that drive inequities in communities. And more importantly for us, it's really about creating pipelines that help to link patients and community stakeholders to resources to address those needs, those identified needs, as Dr. McKeever just pointed out. So she really set us very well. So for those of you who may not be familiar with PAF, we are a national nonprofit organization that addresses access and affordability barriers to care for persons living with a variety of chronic conditions, chronic and complex conditions across the US. So for over 25 years, we have really been at the nexus of addressing individual, social, and financial need gaps that have been exacerbated by unaddressed or underaddressed social determinants of health, by really providing direct one-on-one support to identify solutions to respond to the specific needs that the patients, of course, that we have the pleasure to serve. So when I think about why me, why now, why here, I appreciate that question because I'm here because health inequities exist. I'm here because health disparities exist. And I'm here also because I think it's in our collective energy that we'll bring forth tangible solutions to respond to both of these issues.
Thank you very much, Ms. Chambers. It's great to have you on this panel. Next is Dr. Pamela Coons. Pamela, how do you find yourself on our panel today?
Good afternoon, and yes, thank you for the opportunity and a pleasure to share the virtual podium with these other speakers. So I'm a GI medical oncologist at Yale School of Medicine, and I'm also the vice chief of DEI in our section of medical oncology. I have become increasingly interested and outspoken about workforce disparities and how those can impact patient care, particularly around the topics of gender disparities and sexual harassment in medicine.
Thank you very much, Dr. Coons, and we will get to workforce, I promise you, so we'll get you ready for that as well as other aspects too. Dr. Andrea Willis is next. Dr. Willis, please.
So thank you for the opportunity to be here. I am a board certified pediatrician, and I currently serve as chief medical officer for Blue Cross Blue Shield of Tennessee. And the reason I wanted to be a part of the conversation is summed up in one of my favorite quotes. I quote Dr. William Fagey, a former chief of the CDC, often, and he said in a speech, to graduating medical students, there is something better than science, and that is science with a moral compass, science that contributes to social equity, science in the service of humanity. If we look at what happened even with COVID-19, the pandemic brought all of us to the table. We were all there to help people and to save lives of the most vulnerable. And I think that we all need to be at the table here when we talk about cancer prevention and treatment. And it is important for people to understand that public health is more than the health departments. It's not just about providers, it's about all of us. And believe it or not, health plans are part of public health. And so we're part of the discussion.
Well, thank you, Dr. Willis. I got a hats off to recalling Dr. William Fagey. You're going back a ways, but his star still shines, and that's appreciated. By the way, not everybody might know exactly what a CMO for a Blue Cross Blue Shield plan does. So just at a very high level, kind of what do you do that affects access or payment for cancer care? Just briefly.
Okay, so in my area, I have the pharmacy team, I have the quality team. So we're always looking at how can we improve those quality metrics that really support equity, close gaps in care, things of that nature. That's a huge part of what we do. We also look at the provider community and where we can collaborate there, and who is out there that's a shining example of how we can disseminate best practices across our network. And certainly there are things that we did through the COVID pandemic, things that we had done and supported in the past, but really become a part of the toolbox that we have to use for going forward. And those are things like the expansion of telehealth and telemedicine. We paid those things at parity because they made so much sense and they provided an access and a use of that access like never before. So those are the type things that we can do from our side. So it really is a big collaboration with the provider community and certainly touching the members that we serve. A lot of times the first question is, will this be covered? What do you do? And that opens up a conversation, and we want to use that conversation to really show that we care. It's not just about payments, it's we want people to be healthy.
And I'm glad you answered it that way, Dr. Willis, because not everybody kind of understands or appreciates what someone in your role would do for what sounds like, well, you're a health insurance company. I mean, you know, what could you be doing here? But there you have it. Thank you. This session is going to go until 1:55 p.m. Eastern, so that's 55 after the hour. The topics we hope to get to are preventive healthcare and social determinants of health, equitable access to guideline concordant care, equitable access to quality health insurance, research inclusion and precision medicine, and of course, workforce. And we're going to get into workforce heterogeneity, just kind of set you up for that as well. But I want to start out, if you don't mind, with preventive healthcare and social determinants of health, and particularly Shanta Chambers with you. And so we're kind of understanding, tell us a little bit more about what we know today. What are we learning today about the underlying causes or barriers to effective screening and diagnostic evaluation? What's getting in the way, whether it be SDOH or others, for that? Shanta?
So thanks for that question. And I think I really want to build off of many of what Dr. McGeever pointed out in her presentation around the social determinants of health. But even before I get there, I think it's important for us to acknowledge the impact of all of the isms in our society. In fact, certain groups, and I'm going to emphasize continue. So certain groups continue to experience persistent disadvantages for developing and dying from particular cancers. These are things that we know. So if we ask ourselves, so who are these groups? So they're Blacks, they are Latinos, they are Native Americans, they are Asian Americans, there are people who identify as LGBTQ, there are seniors in our community, and there are those who are living with disabilities. We often forget about folks who are living with disabilities and their risk for other chronic conditions. And it's those who are poor and those who are living in rural communities. So if we really think about that group, we know that no one just has one of those characteristics. Oftentimes, folks are living with a variety of different comorbidities, but then they have these onlay of other social factors. And so it's important for us to understand these things because they also are critical to the disparities conversation. So the individuals that comprise the groups that I just listed, they exist in every single community in our society. Some live in the shadows and others live actually right in front of us, but historical political determinants continue to be the driving force behind the social determinants that restrain their progress. So what do I mean? I'm talking really about their progress towards achieving optimal health. As Dr. McIver pointed out, we're talking about things like health insurance. Let's be very clear, as a result of the pandemic, we really have to take a pause and ask ourselves how many people who were once insured pre-pandemic may now be uninsured post-pandemic. And consequently, that is going to limit their access to care. Those, as a result of other things, we know that people are having to travel in some communities much further for care. So we have these transportation barriers that she talked about. We also have this whole understanding around health literacy and what that really means. So we have to understand that we have a basic literacy problem in our society. So if people don't have the foundation of basic literacy, and now we're wanting to add on top of that health literacy, we're already creating this disparity in terms of how and what people even understand as it relates to their health. So I think, I know we're going to get into this more, but I'm going to wrap this up because I think we cannot ignore the enormity of the impact of the social determinants of health. We want to think about these things as being non-consequential, but I think if we learn nothing from the pandemic, we saw in real time how impactful, unaddressed social needs caused by the social determinants of health can be on one's ability to access and adhere to any course of care.
Well, thank you, Shanta. That list is too long for what comprise the respective social determinants of health. And just a quick answer to this one, if you don't mind, up or down, did the pandemic exacerbate and or call better attention to social determinants of health?
I think for some people it may have actually exacerbated, but I think it did both. I think it exacerbated in some situations, but more importantly, guess what we're talking about now? The social determinants of health.
It's on the program and many like it. Thank you. Well, so Dr. Willis, from your standpoint, given the breadth of activity you do in Tennessee for Blue Cross Blue Shield, what are the kind of the material impacts that you're seeing from social determinants of health? What are the factors really driving these disparities from your vantage point?
So from my vantage point, we did see exacerbations caused by the COVID-19 crisis, but I'll also point out here too that I really feel like we had two pandemics in 2020. We had the COVID-19 pandemic, and certainly deferred care and deferred cancer diagnosis resulted from that. But we also had the pandemic of the social injustices. I mean, we saw racism, we saw a magnification on racism like we haven't seen in recent years. And when we talk about social determinants of health, environment is a social determinant of health. And when racism is there, it taints the environment. It taints how you live, how you work, and just how you experience life. And so those things we cannot ignore because it's those aggressions, whether big and small, and then you experience them every day. It puts people in a box that they have to fight out of every single day. And then how do you turn to a healthcare system that sometimes doesn't even recognize the fight and sometimes doesn't even want to acknowledge the fight? So those are things that we cannot turn a blind eye to.
Yeah.
And we see that in our data. We see who's going in for care, but just as important, we see who's not going in for care.
Dr. Willis, it's kind of, you just told the tale of two pandemics. And you're so right insofar as how they overlapped. And I think something that you just emphasized, and it highlights a point made by Shanta Chambers, is that it's not always sort of factors about me that are social determinants of health or any individual. A social determinant of health is racism on the part of others, is aggression on the part of others. Those are also social determinants of health, as opposed to my particular set of demographic, socio-demographic factors, the data about me. It hurts to hear that, Dr. Willis. It hurts to hear that. Dr. Coons, from your standpoint as a provider, and in particular, if you want to take it down to gastrointestinal cancers, how do these SDOHs sort of manifest from the perspective of the work you do as an oncologist?
Thanks, Cliff. You know, I think one really good example that I'm sure we can all speak to recently is colon cancer screening. And, you know, this year, I think the recommended colon cancer screening age for average risk individuals is down to the age of 45. But I think that we've known for a long time that Blacks are at a much higher risk of colon cancer and worse outcomes from colon cancer and have lower screening rates. And in fact, some guidelines organizations, including the NCCN and the American College of Gastroenterology and ACS, had advocated for earlier screening, but the USPSTF is held to some higher levels of evidence in order to make those recommendations. So I think that's one is, I think I'm pleased to see that those recommendations have come out, but the next step is really implementing it in the communities in which it matters. And I think that we as a community have to figure out what those barriers are. And I think that some of our earlier speakers spoke to that. How can we, you know, use the crisis of the pandemic to be innovative and do home-based testing? You know, any screening is better than no screening. So if colonoscopy does not work for a particular individual or community, can we do home-based FIT testing? Which examines for microscopic blood in the stools? Can we do mobile to switch types of screening, mobile mammogram vans? I think we have to use the crisis of the pandemic to evaluate that.
Dr. Coons, do you see on a day-to-day or otherwise frequent basis examples of exactly how social determinants of health are getting in the way of the care that you want to provide patients? Is it that they show up less often, or it's harder to communicate, or people are less willing to take on a treatment? How does it show up in what you do?
Well, there are so many examples. Let me think of a few. I mean, I think there are insecurities around lost work for patients that are coming in for both appointments. I had a recent conversation with a patient who didn't want to go on treatment for a metastatic cancer because he was worried about how much time off work he was going to have to take. Wow. We fortunately had resources with a wonderful social worker who helped walk him through what some of his options were for paid leave, and he fortunately chose that option. But I think it's around providing optimal education for our patients. So I think whether it's in an academic setting or a community-based setting, we need to provide those types of resources to address the social determinants of health.
Wow. Shanta Chambers, did it hit you just now that Dr. Coons posed a trade-off between late-stage colon cancer chemo and making it to work?
No,
that hit me pretty hard.
It doesn't surprise me, unfortunately, and it's unfortunate that it doesn't surprise me, because when I think about the patients that we serve, those are the trade-offs that they're making every single day. So there are individuals who may be uninsured, underinsured, low income, working jobs where they don't have paid time off. They may be the sole breadwinner for their entire family. There are so many dynamics coming into play that they are having to make these critical decisions every single day. And so I'm not surprised, unfortunately, because I know of a story also in the Tennessee area where a woman where a mass was found, but because she was a single parent, she says, I'm going to have to delay my treatment so that I can work and bank some additional funds so that I can care for my family while I'm in treatment. I think it's important for us to really, really understand the economic consequence of disinvestment in communities to build the infrastructure that really helps them fortify themselves in a way that they can address their health timely. People are making these kind of decisions every day, unfortunately.
Well, thank you, Ms. Chambers. And Andrea Willis, Dr. Willis, since Shanta mentioned your state there, I want to ask you about what we're calling guideline concordant care. In other words, if NCCN or anybody else's guidelines, USPSTF for that matter, say this is what people ought to get given their particular indications, are you seeing any fall off to guideline concordant care because of these social determinants of health? In other words, are we missing opportunities to treat people the way we know we should treat them based on evidence-based guidelines?
We are missing people. I mean, that's something that we always strive to do, is to find out the ways that we can outreach to people. Sometimes people don't understand the importance of the guidelines, but because we do, it's on us to find ways to really help translate that to the people that we're trying to serve. And so we have started to do things like, even in our first interaction with our members, the first question is, what can we do for you today? So even though there are some guidelines that we want them to follow and that we want to get to rather quickly, if we don't address barriers to them getting to that care, then we failed right there. So we've learned to retool our conversation. We might not get to the guidelines that first day. We might not get past to what can we do for you today. The other thing we try to do, oh, I'm sorry, go ahead.
No, please finish. I'm just remarking.
We also try to really tailor our outreach. If we see somebody has gaps in care, to say specifically, Miss Smith, we've seen you've not gotten this. So we want her to know that we're looking at you and we're trying to address your circumstance to help you get to the care that you need.
You know, I just wrote that down next to where Dr. McKeever's statement about non-traditional partners and who is missing, when you said, the first thing is, what can we do for you today? I do a lot of work in evidence-based clinical practice guidelines, and I have to admit, recommendation number one has never been, ask the patient, what can we do for you today? And what you're demonstrating is that getting them to guideline concordant care may not be the first thing you got to deal with. The first thing you may have to deal with is, are you secure at home? Is there enough food on the table? Where are the kids and so forth? How did you get here? How are you getting home? So a painful point well taken, I must say. Dr. Coons, insofar as, let's look at GI once again. When you think about GI care, and I know that you know a lot about NCCN and other guidelines in this area, can you talk a little bit more about where we're falling short? Are there any particular areas where we're just not hitting the mark?
Yes, I'd love to maybe change the subject just a little bit and address guideline concordant care for our LGBTQ plus population. And I think
Go
that,
right ahead.
You know, to points made earlier by Ms. Chambers and by Dr. McIver, you know, addressing all of the isms are really important as we think about equitable care delivery. And I think that our guidelines have language that make many of our LGBTQ plus patients feel invisible. And I think that,
tell us what
so
language?
I'll give just an example. So for example, for breast cancer, if we have a trans individual who may be at risk for breast cancer, but may no longer have breasts, we think of as chest tissue and have a risk of breast cancer. The guidelines should not say women, they should say people. And same for prostate cancer. We should have organ-based guidelines as opposed to them being really sex-based guidelines or guidelines based on sex assigned at birth. And I mean, I'm learning constantly. I mean, this is, I think, an area that I, you know, am eager to see some advances in terms of more inclusive language. And I think I will say that the NCCN has already been starting to do some work on this. colleagues and friends of mine, Dr. Juno Obedin-Maliver and Dr. Ash Alpert, have recently given a presentation to the NCCN on this exact topic. And I'm happy to say that they are working on developing inclusive language in all of these guidelines. And I think that's part of the low-hanging fruit that we can really start changing.
Wow. So the aspect of inclusive language, it's not only a matter of fairness, but it sounds like you're saying if we don't use appropriately inclusive language, we're basically going to turn off or even turn away people that need our care. So once again, if you want to get to guideline concordant care, you ain't going to be able to do it if people feel like they're being excluded, right? If you use the wrong terminology.
Correct. Well, and I may also, turn to Dr. Willis. I think that some of these can have implications on what gets covered. In terms of if we have a trans man or trans woman who may or may not be eligible for mammograms, pap smears, et cetera, that may be based on sex assigned at birth, as opposed to their gender identity or their other characteristics. So again, organ-based screening is really where we should be headed. Organ-based
Screening as opposed to saying this is a test for a male and this is a test for a female. So Dr. Willis, does that sound concordant to you? And do you think across the payer community, people are becoming aware of that important issue?
I do think that we're becoming aware of that issue and definitely trying to catch up. I mean, I won't say that we're totally where we need to be today, because a lot of the policies we review, we do on an annual basis. So it might be that we're not quite up to this particular policy this month. We might be there next month. And so when we get to them, we try to make those changes. So definitely the awareness is there. Definitely the effort to change it is there. And then as we're coming across the policies for annual review, that's when we try to incorporate the changes. So it'll take us a little while. I won't lie about that, but we're trying to be there. We're there conceptually.
Yeah, so many of us, myself included, we're working to get our pronouns corrected and adjusted to where they need to be. And I got to admit, I slip from time to time, but my daughters will remind me from time to time, so good for them. I want to ask a question that my colleague Bob Carlson noted to me not long ago, and because I think it was Dr. Coons who might have mentioned USPSTF or maybe Dr. Willis, and that is guidelines that are based on research data, let's say for randomized controlled trials, those RCTs may not have been properly representative of the target population. And if they are not properly representative of a target population and the results are incorporated into a so-called evidence-based clinical practice guideline, are we truly going astray? Did we miss something there? Dr. Coons, you're nodding your head like you know about this. Would you mind addressing that for starters? And I'm really interested in Dr. Willis's and Ms. Chambers' reactions as well.
Sure, I'm happy to start. So another hat that I wear is as a clinical trialist. So I am on that side of the fence. And I think that admittedly, we need to do a much better job of more inclusive eligibility criteria for clinical trials that are more representative of real world populations, and therefore, the decisions and evidence that these guidelines are based on, they will be based on less restrictive data. And I think that that's something that is happening. So there was a recent, I would say an ongoing and updated document that's through ASCO and the Friends of Cancer Research. I know we had a speaker earlier from that organization. And I think there are efforts at, again, trying to broaden these eligibility criteria. So I think it's a recognized challenge, but an opportunity that we can certainly do better.
Thank you. Dr. Willis, similar, because after all, at some point, your organization does make decisions to pay or not to pay for certain therapies and so forth, and it's supposed to be based on research. Does that concern you?
It does concern me. And I think especially with our being based in the South, that we definitely have those historical constructs that sometimes will, keep people away from clinical trials. And so we have to be sensitive to that. So I think as we're trying to do things to help people, that we have the opportunities to introduce that concept of participating in clinical trials, but we want to meet people where they are. We have to form that relationship. We have to have that trust. And sometimes that means partnering with someone else in the community that really might garner more trust. For example, we have a partnership with Meharry Medical College. Sometimes that messaging would be much better from Meharry than it would be from us. So trying to recognize that we need to have the conversations, but also trying to recognize when we're not the appropriate ones or the best ones to have that conversation.
So a lot of it has to do with who is the appropriate messenger, the trusted messenger. Thank you. And so Shanta Chambers, then, are you concerned as well that a potentially biased research base ultimately gets incorporated downstream into guidelines and care patterns that may be biased as well?
Hasn't that been our history? And I think we have to, it's like, whose evidence is it, right? So when we really think about, if we look at just historically, we have therapies, we have products, we have even our guidelines, right? It's all based, and we're having a conversation around the limited number of diverse individuals that participate in clinical trials. That's our conversation. And so I think we're kind of answering our own question. Everything that we've developed thus far has been exclusive of the very populations that we're talking about. And I think earlier in today's summit, Keisha Brooks Coley pointed out that ACS had actually done some research that looked at two things that you pointed out. I think one, we have to acknowledge the bias that can also be infused into hindering the application of guideline adherent care. And I think secondly, one of the things she pointed out is that for the survey participants, they acknowledged the fact that their healthcare provider had not even had a conversation with them about clinical trial participation. I think the underbelly of that may be some bias as well. Are there perceptions? And let's just be very real that we do make perceptions about individuals based upon the first 30 seconds that we see them. So we have to ask ourselves, our path forward is acknowledging and addressing both implicit and explicit bias, no matter where it's existing. And our unwillingness to do that will not bring us forward in a way that I think will be most productive for the entire population.
Explicit and implicit bias, and I wrote down as well when you said, whose evidence is it? After all, Shanta, if you don't mind a follow up on that, because we've had some references to real world data and real world evidence before. Do you think, because you deal with such an extraordinary diversity of patients at PF, do you think that some other kind of sources of real world data, from claims data, electronic health records, social, economic data, can those help rebalance a little bit some of that earlier bias? Can that help us out in this issue?
I think we have to look at our system designs, right? Because if we haven't designed our system, our data collection systems in the right way from the beginning, our outputs are going to be what the system is designed to output. So I can design a system to tell me whatever it is I really want it to tell me. So the question we really have to ask ourselves, do we really want to design systems in a way that really show us these very factors that may be impacting care, including the social determinants of health? Do we want to make sure that we are designing systems that routinely capture SOGI data, or not just when it's convenient? And we have to make sure, are we designing systems in a way that really get at the underbelly of what patients say that they need, and design it so that the communication process between a patient and provider is one that is responsive to, how can I help you today? And bring together the patient expectation and the provider expectation, bring it together in a dialogue that really helps to move individuals forward.
So you're talking about systems redesign then. It's not just a tweak here or a tweak here. This is a redesign issue from the ground up. And it's just recalling what we just heard a bit ago, the redesign cannot be siloed in on medical/healthcare alone, correct?
Correct.
Okay, so that's a message we're hearing here very strongly. Dr. Willis, I'm just wondering, speaking about real world data versus clinical trials, are you able to dip into, under protected circumstances, of course, Blue Cross Blue Shield data sources to help let you know what's going on insofar as appropriate and fair access?
We are digging into that more. Certainly with COVID-19, we were combing our data to see, as the best practices were coming forward as far as treatment goes, we were looking at demographic data to try to see, where those things were being applied, and trying to be a conduit if we found out, hey, maybe that best practice hadn't gotten over here. We didn't want to point fingers, but at least try to make sure we shared data across our providers. And then again, I'll mention Meharry Medical College. They are one of our partners, and we were able to, certainly we had to run it by legal and all of that, but share some de-identified type data to make sure that we were really focusing on those vulnerable populations. So that work is still ongoing, and we hope to be able to use what comes out of that to go out and then, provide education, not only to our provider community about what the experience was by what we see in the data, but we also want to be able to educate policymakers, because we think they have a role in this when all is said and done.
Got it. So these other data streams not only complement, but might even help correct some of the biases in the research base, it sounds like. So that's an important take-home point. Pamela Coons, just coming back to you on workforce here. Tell us, I'll say enlighten us about the disconnects in our healthcare workforce, maybe even in the oncology workforce. Where are we going wrong here, and how do we kind of redirect to correct it? What's the workforce homogeneity, or maybe say lack of heterogeneity issue?
So yes, I mean, this is a real challenge. And I think I really like to think of workforce disparities and disparities for patients as two sides of the same coin. I think we really, in order to provide equitable patient care, we need to have a diverse and equitable and an inclusive workforce, or we won't be, asking innovative questions. We won't be thinking differently. We won't have diverse teams to be problem solving. We won't be thinking about including SDOH in our research. And I mean, it goes on. And I think, so I think that there has historically been a real lack of diversity in medicine. I think that that spans many different characteristics. It includes sex, gender, race, ethnicity, LGBTQ. I mean, again, going back to Ms. Chambers' comment, it's the intersection of all of these isms. And I think that, in the workforce in particular, if a physician or another provider has an intersection of these characteristics, they often face additional burdens of discrimination or disparities. And so I think COVID actually has really brought that to light as well. We've seen some real workforce disparities around more female physicians leaving the workforce, additional disparities and burdens on physicians who associate with being BIPOC or LGBTQ+. I think that it's really brought that to light, and I'm hopeful and energized that we're having conversations like this. And so there are, I think, some potential solutions to that. They will also require real systems changes, but I think that creating a more diverse and equitable workforce is critical. We need to create more diverse leadership structures. We need to limit taxes on, kind of quote, taxes on individuals who are doing the work to promote an equitable workforce.
Is that all?
No, I could probably go on and on.
Well, gosh, Shanta Chambers, then, from the standpoint of, I know you work with so many patients, but I know you work with a lot of healthcare providers too. Are we kind of at a hopeless disconnect between the kind of productive interaction that would be sought by patients of our diverse patient population and the people who are serving them? Is that kind of a fatal problem we've got here? Is it even soluble?
So I'm an eternal optimist, so you'll never hear me say anything is hopeless. I think the fact that we are at this place in time and that we are having these conversations and we're acknowledging what is not happening and what needs to happen. I really think our path forward is going to require us to be bold, to be innovative, to be uncomfortable. And I think our willingness to lean into that discomfort or uncomfort is where we're going to find our most creative solutions, our most sustainable solutions. And so I think that, one of the things I do want to kind of highlight here is everything that we've talked about today. The Elevating Cancer Equity Work Group, which is a collaborative project of NCCN, National Minority Equality Forum, and ACS-CAN, brought together 17 thought leaders. And through that body of work, one of the things that we came out with a set of recommendations. And for the very first time, what we talked about is an equity report card. Now that's provocative, that's being innovative. And it includes everything from address institutional and practice changes that address everything from community engagement, accessibility of care, the social determinants of health, addressing bias in care delivery, and quality of comprehensive care. So everything that we've talked about, this set of recommendation is like that lighthouse that's in the distance for me, because what it reflects is that some very tangible things that all of us could do, no matter where we are in the ecosystem, because as Dr. McIver pointed out, it is going to require the engagement of non-traditional partners for us convening in a very different way so that our new normal doesn't end up being another abnormal.
Well, I got to say that when you said equity report card, the hair that I still have on my head kind of stood up, because I was thinking that, that we've done so much work in quality measurement. And of course, Dr. Willis, that's one of her things is quality measurement. Can you imagine having an equity report card that would be transparent to the healthcare providers and patient communities and our various cancer centers? Dr. Willis, can you imagine such a thing? Can we put together a valid, you're a measurement person, equity report card that we could kind of put out and say, look, this is how this institution is doing? I'd be a little nervous about that, but what do you think?
I think people should be nervous about that because we really want to shine a light. And anytime you do that, people are going to be nervous, but we have to institutionalize it. So as we think about value-based payment models going forward, we're trying to incentivize based on quality, but quality for whom? I mean, we really got to make sure it's quality for everybody. That needs to be a part of it. And if you put it in something like that, it becomes institutionalized. And I think over time, it gets refined for the better.
Wow, I'm just thinking about this. Too bad Dr. McKeever's still not here, because we might put this on her already full docket of stuff, which is, Dr. McKeever, maybe CMS ought to have an equity report card, just the way it's got the STARS program or something like that, right?
They are included in the recommendations, Cliff, just for a note.
Oh, say that again, please.
We actually included in the recommendations some roles for everyone across the ecosystem, including policy-related activities, and specifically, we noted CMS. So we wanted to make sure that we did look around the table and say who's missing, and we extended through this equity report card an invitation for engagement.
So you're already ahead of us now. Good gosh. Well, I hope people listen to that. Well, Dr. Coons, as someone who works in an oncology care institution and is a provider yourself, you think we ought to welcome something like an equity report card that really enumerates criteria and factors and scores you up on something like this? Well, will that prompt the response that we need in more broadly?
I think it's a great first step. I love the idea. And I think that it's To speak to some other comments made, yes, it's uncomfortable, but I think I love Ms. Chambers' comment that we have to lean into the discomfort. I think also a really first key step in addressing any of these disparities is measuring them. And I think that this equity report card, developing key metrics that we consistently measure across all of these sectors is really the only way we're going to have a baseline knowledge of where we're at in order to improve.
Wow. Dr. Coons, you mentioned something earlier, and I can't remember the statics exactly, but I think I saw something recently about one of the highest risk groups for violence was transgender people of color. Did I see that correctly? And it almost looked like a spike compared to some of the other data. It was so bad. Is this having that threat? Is that having a lifelong deleterious effects on people, as well as even how well they can take care of themselves and present for preventive care and so forth? Just the fear of that?
Of course. I mean, I think it goes back to, what many of us have commented on, which is the intersectionality of marginalized characteristics, and that each of these then can compound the other and create additional burden and risk. And I think that then that also becomes, as Dr. Willis said, the environment becomes this additional kind of social determinant of health. So I think absolutely, Cliff, I think these are, I think it gets complicated, admittedly, to address the intersectionality. But I think that, again, as we're having these conversations, recognizing especially at-risk groups is important to make sure that we're targeting those groups and trying to overcome specific challenges for those groups.
Shanta Chambers, that term of intersectionality of marginalized groups, is that a term of art that is familiar to you? And are you seeing its implications in your work?
Oh, absolutely. So the patients that we support, they don't just come to us because they have one need. They're coming to us because they have a myriad of needs. And so it may be they are uninsured. They may be uninsured and they may live in a rural community. They may be insured, but it may be an underinsured situation, or the quality of care that they actually have access to. Or you may have we've done a great job in being able to increase women's access to mammography screenings through some of our screening and early detection programs. However, what I hear from some communities becomes this gap. If something suspicious is identified, getting that woman or male or whomever from a screening mammography to a diagnostic. So if we can never close that loop, then the chances of getting them into treatment earlier, that is also at risk. So we have to stop thinking about things in a very singular silo kind of approach. Individuals have a variety of different factors that are all coming into play. When you start to think about limited resource, marginalized, disadvantaged, underserved, however we want to characterize them, they are dealing with a myriad of factors all operating at the same time. And at the end of the day, the one thing they're trying to do is survive.
Survival, not a bad trait to pursue, but gosh, so many of them are subject to threats to their survival. So many of the people in our communities. I want to pose a last closing question to the three of you. And I'll ask you to answer just a sentence or a sentence and a half. And that has to do with public policy change. I know Dr. McKeever listed a couple of the EOs, those executive orders. I know that people in Congress are trying to do various things, but from your respective standpoints, first Dr. Willis, Dr. Coons, Ms. Chambers, is there some policy change, single policy change, that if you could pull the lever would have the greatest impact on closing these disparities of which we spoke today that are so prevalent? Dr. Willis, if you could kind of just do one policy change, whether at a state level, national level, or other, what might that be?
I think we've really touched on it for me, and that is to institutionalize really addressing the quality of care by putting it into value-based payments. I really think that would make a difference.
So really make an explicit connection to value-based payment. So if you want to get paid, you need to do maybe score a 95 or above on the equity report card or something. Okay, point well taken, very objective. Dr. Coons, what would that policy change be?
I think I'd like to build on some measurement of key data elements across sectors, whether it's the equity report card or social determinants of health or marginalized characteristics.
So once again, you're hitting on specific measurable criteria then, not just sort of qualitative ethereal stuff, but give me the factors, give me the data. Thank you. Shanta Chambers, if you could pull one lever, I know you'd like to pull a bunch of levers, but if you could pull one, what might that be?
And that would be reimbursement for social needs assessment and navigation, whether that is internal to the health system or through collaboration with community-based organizations.
So again, specificity with regard to getting paid, coverage and appropriate reimbursement for these services. They're not add-ons, they're not extra, they're a specific part of a regimen of care, basically. Thank you very much. We are at the end of our minutes, but we could not have done better. Good gosh, on behalf of NCCN community and all the, gosh, how many hundreds of people have been on here, Shanta Chambers, Pamela Coons, Andrea Willis, thank you for, well, I'll use the term again, enlightening us on these issues. We really appreciate the pragmatism and practicality you bring to this and the objectivity for solving these problems. They are concrete issues. You've given great solutions, proposed solutions, and you personalize some issues that we just haven't captured and enumerated as well as we have. So thank you so very much on behalf of all of us. It's been great sharing time with you and learning from you. So with that, I'm going to hand it over to Gary Waymuller of NCCN for his any observations and closing remarks. Over to you, Gary.
Thank you, Cliff. We've had a really information-packed day, very powerful. I just wanted to thank everyone who's attended today's policy summit. I'm Gary Waymuller. I have the pleasure of serving as the Chief Operating Officer at NCCN. And I wanted to thank you all for being with us today and spending your time with us to participate in this summit. I'd also like to thank all of our keynote speakers and panelists, and especially our moderator, Dr. Clifford Goodman, for his leadership through today in bringing these sessions to life. We've had a lot of thought-provoking discussions, and it's been a really great morning and afternoon. And secondly, if you've enjoyed today's programming, I'd like to call your attention to the remaining policy summits in our 2021 Oncology Policy Summit Series. Registration for our September summit, The Impact of Technology on Cancer Care in 2021, will open shortly. And lastly, I'd like to thank all of the supporters of our Policy Summit Series. Again, without your support, we could not make these programs possible. So thank you very much for all that you do for us in allowing us to put on these valuable programs. And a special thank you to the entire staff of NCCN, especially our conferences and meetings team that organized this and carry it out, our policy team that has pulled this together, and in particular, Terrell Johnson, who has been the lead on this series today. We want to thank everyone again for your time and attention today, and please continue to participate with us as we go forward. Be safe, and hopefully we'll see you again in September. Thank you.